Good morning, all. You are all welcome to this Saturday's session. And I think our facilitator is ready. So sorry for keeping you waiting for some time. Without wasting much time, I will hand over to our facilitator to continue. You are welcome, sir.
Hello, Dr. Somani, good morning. Our participants, senior colleagues and colleagues, good morning. I think you can unmute yourself so that at least I will know that I'm audible.
Yes, good morning, sir. You are welcome.
Okay, the other time we had serious challenge with the internet, so we have to be going on and off because of the internet issue. I pray that today we will not have a serious challenge with the internet. It's not like the internet you have in Hong Kong. So is my screen visible to participants?
Yes.
Okay, my name is Naziru Bashir Mukhtar. So I'm a senior lecturer with the Department of Physiotherapy, Bayero University, Kano, and also a visiting assistant professor with the Department of Physiotherapy, Mariam Abacha American University of Nigeria. For those that know me, I graduated from Bayero University, Kano for my first bachelor degree, and I obtained my MSc and PhD from Poland and Belgium, respectively. I have practiced as an orthopedic physiotherapist with National Orthopedic Hospital Dala Kano for some years before joining academics. Although I'm fully in academics now, I still have some private practice where I predominantly see orthopedic patients. So I think this is a little information about me. I think it would be good if maybe the participant that joined, if we will have maybe some few introductions and maybe some expectations from the workshop, then I can go ahead with my presentations. Do we have to be calling names or participants have to indicate? Participants. Hello?
We can hear you, sir. Oh, I can hear you, sir.
Yes, we can have some little introductions.
Hello, good morning.
Yes, okay. Zainab Adam, are you the one talking?
Yes, my name is Adam Zainab Abdullahi. I am an assistant director of physiotherapy in FCTA Kubwa General Hospital, Abuja.
Okay, and do you have any area you specialized in?
No, not yet, but I'm planning to specialize
So
in
like a general
orthopedic.
practitioner?
Yes, I'm a general practitioner.
Okay.
But I plan to specialize in MSK
Okay,
and orthopedic.
So you see many spinal pain patients where you practice?
Yes, I do.
Okay. Dr. Okunwa Abimbola.
Yes, good morning, sir.
Yes, good morning.
I currently work in General Hospital Ijede, which is in Lagos State. You can call me a general practitioner as well because I'm currently not specialized in any area yet.
Okay. So you are here to get more experience, to get more money?
More like the experience and also CPD, then also the experience, because most times as general, what is most common is the auto conditions, neck pain, back pain, knee pain, and it doesn't hurt. You always want to learn more in the process.
Okay, that is interesting. Who else? Do I have to call names or you just indicate yourself? Adesegun Oluwatoyin Adetola. Amir Musa.
Good morning, sir. My name is
Yes.
Amir Musa, a physiotherapist. I graduated from University of Maiduguri. That is in 2013, and I'm currently practicing in Jos Plateau State in one private clinic. Yes,
Okay,
sir.
so you often see orthopedic patients?
Yes, sir, I do, sir.
Okay. Babatunde Kazim Olalekan. Benedicta Omoijahe. Blessing Bamidele. Is there any other person that would like to introduce him or herself?
Yes, sir.
Okay, go ahead.
Good morning, sir. I am Salmane Abiliaminu, graduating from Bayero University, Kano. I currently work at private clinic.
Where?
I'm a general practitioner and want to specialize in musculoskeletal and sport physiotherapy.
Okay, where do you practice? In which part of
Private
Nigeria?
clinic.
A private
In Kano,
clinic can
private
be
clinic. Yes,
in
Kano.
Kano.
Kano State.
Okay.
Yes.
Okay. Who else? So I think we can go ahead.
Hello, sir.
Yes.
So I am by name Muhammad Ali.
Okay.
I graduated the same class with Amir Musa Tilde.
Okay.
So I currently practice at Federal University of Teaching Hospital, Azare. That's Pusta.
Azare.
Yes.
Okay. Do you have any field where you specialized in, or you also practice as a general practitioner?
Yes, there is. I'm currently practicing at under orthopedic units, sir.
Orthopedic. Okay, that's good. Okay.
Yes, orthopedic units.
Okay. Who else?
Good morning, sir.
Yes. Good morning.
My name is Binovia Frank. I'm a prospective corps member.
Okay, that's good.
Yes, sir.
Okay. So where are you serving?
I'm not yet started serving. I just finished my internship.
Okay.
Yes, sir.
Okay. Thank you.
You're welcome, sir.
So I think we can just go ahead. So as part of the things we have introduced ourselves, sometimes I ask, even in my previous workshops, about the expectations. I don't know what my participants are expecting from the workshop. Sometimes from their comments, maybe I have to adjust my presentation, include some things, so decide to be silent on some things, or we have to arrive at some agreements. So can I have some expectations from the participants, what they expect to learn from the workshop? Participants, are there expectations? Participants.
Yes, hello.
Hello, yes. Dr. Ngene
Good
Michael.
afternoon. Thank you,
Yes.
everyone.
Is it afternoon
my
over
name is-
there?
Yeah, it's just after 11. It's 16 after 11 here in Nigeria because I'm tuning in
Okay,
from
after 11
Nigeria.
is afternoon.
It's morning. It's still morning. It's not yet 12.
Okay.
Yes,
Yes, sir.
it's still morning.
I'm listening.
Okay, I have my own expectation. I would want to know the impact of spinal manipulative therapy. You know, some people call it chiropractic adjustment. In the effectiveness and the physiotherapy significance in managing chronic neck pain.
Okay. So spinal manipulative therapy.
Whether it has, I would like to see if there are any literature reviews, evidence-based practices currently on the use of spinal manipulative therapy managing chronic back pain.
Okay, that is interesting. I think we have to touch that. Okay. Thank you for your comment. Yes, who else? Umar A. Ahmad. Who else?
Yes, good morning, sir.
Yes, good morning, sir.
My name is Abubakar Yahaya, a general practitioner from General Hospital Funtua.
Okay.
My expectation is that we all know that cervical spine is a sensitive area. It's a sensitive part of the body. So, sir, I'm expecting that you are going to shed more light on precautions on managing cervical spine chronic pain.
Okay. That is an interesting one. Okay, who else? Participants, who else? So are these two the only expectations? I should just handle them, then if we finish, if it is in 1 hour, we just call it a day?
Good morning once again, sir. My expectation on this workshop is that, sir, you will talk more about interpreting the radiological images.
Okay.
Sir, yes.
So it's like in your PP, you ask them to make a lot of radiological images, yes? Yes, who else?
Hello, sir.
Yes, I'm with you, Dr. Abimbola.
Okay, another thing is the point of orthosis when it comes in, and which type of orthosis, whether soft, semi-rigid, or rigid, depending on the condition.
Okay. So I think we can go ahead, yes?
All right, sir.
Abla Abakar Muhammad, are you trying to talk here?
Good morning, sir.
Yes, good day. Dr. Umar Ahmad.
Good morning, sir.
Yes, good morning.
I'm calling you from Jos University Teaching Hospital.
Okay,
and I happen to be your student in BOK, so I'm glad to be here, sir.
Okay. Are there expectations? Hope you are not expecting me to give you money here.
Not really money, sir, but if you can give, sir, it will go a long way.
So what are the expectations?
Sir, my expectations are concerning the radiological investigations.
Okay, someone has already raised that issue, okay?
Yes, sir. And then the outcomes for poor diagnosis, sir.
Okay, outcomes, then issue of diagnosis,
Yes,
okay? Okay.
Yes, sir.
Okay.
Thank you very much.
Okay. I think all the issues raised have already been taken into consideration in what I planned, but do I have some more responses?
Okay. Good morning, sir.
Yes, good morning. Okay.
Sir, my expectation in this presentation, I hope you will explore more on physical examination, like provocative tests.
Okay, physical examinations, provocative tests.
Yes, sir. Thank you. Sir.
Provocative tests, okay. Because I'm noting them down to make sure that I'm not missing things. So are we done? Can we go ahead? Okay. So I intended to cover the course under the following synopsis. We will have an overview of neck pain, and in that we are going to pay more emphasis on chronic neck pain. Then we will discuss about possible causes of pain and all limitations of movement in the neck region. These ones are going to be the possible causes because we have to discuss a lot of other things that may be the reason why someone is having pain that is persisting. We have to talk about subjective examination, where we need to discuss about the body chart, behavior of symptoms, history of the present condition, relevant medical history, social and family history, then the plan of the physical examination. Then we go ahead and discuss on how a patient with chronic neck pain should be physically examined. What do you need to observe? Then the passive intervertebral examinations. Someone has already asked about provocative tests, so neurodynamic tests, joint range of motion assessments, then sustained apophyseal glides, muscle tests, then biopsychosocial assessment, outcome measure administration. Then at the end, we have to talk about evidence-based management of chronic neck pain. So as part of the definition, those that have attended also the similar course we had on acute neck pain, we have to define neck pain. The definition will not differ, but the duration has to now differ because chronic is always differentiated from acute by its duration. So neck pain is considered to be a pain and discomfort within the anatomical boundaries of the superior nuchal line, superiorly, then inferiorly up to C7 spine, and then laterally up to the medial margins of right and left scapulae. So pain around these areas, in any part of these areas, is clinically defined as neck pain. Neck pain can be of sudden onset, but it will not be considered as chronic neck pain unless if it has lasted for more than 12 weeks. This is the most common definition of chronic pain, but in some, they consider pain to have lasted for up to 6 months. But clinically, the most common definition and often used is for 3 months. So if pain has lasted for up to 12 weeks, then it is considered chronic. So any pain around this anatomical region that have lasted for up to 12 weeks, then we consider it chronic. It is very good that we have to, when we assess our patient, clearly mention if our patient has acute pain, subacute, or chronic pain. Because in the concept of evidence-based practice, it probably you have an evidence that this intervention A or intervention B is effective or is ineffective in the management of a certain condition, then usually it is attached with the definition of the condition. So if intervention A is beneficial to acute neck pain, then after clerking and assessing your patient, and your patient happen to be the one with chronic neck pain, you cannot extrapolate that result and say this intervention is beneficial in neck pain. Yes, it is beneficial in neck pain, but only in acute neck pain. So we have to clearly get the information from the patient and adequately define the pain of our patient to either be acute or chronic. So in this case, we are handling the chronic one. And then for the chronic neck pain, it may or may not be associated with some radiation. And this radiation can be to the head region, to the shoulders, or to the upper limbs, usually the arms. Also, this needs to be clearly explained while assessing your patient. Your patient is having maybe chronic neck pain with radiation to so-so region. So that when you are managing the patient and you want to use an evidence, if there are evidence that are saying intervention A or intervention B is beneficial in chronic cervical radiculopathy, then till when you are able to assess your patient and define your patient to have pain in the neck region that is chronic, that has lasted up to 12 weeks, and is also radiating to the certain regions, then you can now use that evidence that says intervention A is beneficial in that situation. If your patient is having pain with the radiation, but the pain may be lasted for only maybe 4 weeks, 6 weeks, 7 weeks, then that is still an acute pain. The evidence that says it is beneficial, but in chronic neck pain or chronic radiculopathy cannot be used in that your patient, because the population have completely differed. Chronic pain patients population is different from acute neck pain population. So we need to take this into consideration. Then mostly not associated with injuries. We need to be very clear about this. In acute neck pain, mostly it is associated with injuries, because in acute condition, something might have happened to the body and the body is now reactive. And the easiest way for the body to react is to have pain, so that there will be protection and you need to seek medical attention. But in chronic neck pain, in most of the cases, it is not associated with injuries, wear or tear, or abnormal posture, or associated with initial possible cause of the injury. So probably they may mention certain injury, but the injury has already healed. So you cannot clearly say it is this injury because the injury is no more there. So this is one classical issue that we need to be careful with. And from the expectations, our colleague mentioned the emphasis on interpreting radiological images. So that is why here at the introduction here, at the definition, I need to also emphasize on this, that our colleagues should be careful on how they request, they interpret, and they relate the results of radiological investigations with the condition of their patients that are presenting with chronic neck pain. Not just neck pain, chronic spinal pain. When you look at radiological images, you are trying to find a fault. You are trying to find a pathology. And in many chronic conditions, it is not associated with the pathology in many. and certain few ones, it is associated with the pathology. So by the time you already linked it with pathology, so you are trying to see that you want to eliminate the pathology, you want to make the pathology better before your patient gets better. And that pathology that you think is existing might not be existing because we have false positive results. Individuals may present with radiological images that if you are not told that this is, for example, an X-ray of a healthy individual that has no pain at all, by looking at the X-ray results, you may start prescribing intensive physiotherapy and pain relieving methods, because to you, this pathology cannot be there without pain, when in the actual sense, there could be those changes without pain. That is, pathology or injury is not always associated with pain or always correlated with pain. So we have to be very careful with this. So for us to continue, we also need to talk about a little epidemiology and burden of neck pain, because when a condition exists, we need to also talk if it is serious so that we can spend our energy and resources looking at it, researching it, and trying to find the best way to handle it. If it is a condition where in 1 million individuals, only 1 or 2 individuals may have the condition, then we may say it's not something serious, so we don't need to spend resources trying to find solutions to the problem. In 2016, among the 154 conditions, low back pain and neck pain had the highest healthcare expenditure in the United States of America. Most of the times reference is made to United States of America because of the data they have. They always publish the data, so it can be used as a guide, as a reference point, but still local data is always encouraged. So among the 154 conditions, low back pain and neck pain, which together we consider as spinal pain, they had the highest healthcare expenditure. So it means finding a lasting solution or the best way to handle these conditions is very important to the welfare of the patients, the sufferers, and to the economy of the country of concern, so that the huge amount of resources that are expended on that condition can now be used for other activities that will improve human life instead of spending them on managing pain. In addition, its cost included not only direct but also indirect ways such as loss of productivity. This constitutes a burden not only for the patient with neck pain but also for social and economic systems. There are indirect loss of productivity that are associated with neck pain, where an individual that is expected to work now because of the neck pain is either less productive or completely non-productive. So the services that are expected from that individual, that patient, is now not able to go and discharge such responsibilities. So all these are parts of the burdens, and neck pain being among the leading ones, then all these are associated with neck pain in our societies. So we need to handle this. So neck pain is one of the most common musculoskeletal disorders, having an age standardized prevalence rate of 27 individuals per 1,000 population, as reported by Kazemi Nasab in 2019. So in every 1,000 individuals, you will get 27 with neck pain if the age is standardized. But we have certain ages where the neck pain is more prevalent and certain ages where neck pain is not common. The economic burden of neck pain is remarkable and includes treatment costs, which in most of the researches that we do locally, individuals pay only attention to the cost of the treatment.
So, why am I I'm running because I believe the Assistant Secretary's Office is not just an administrative seat, it is a strategic role that supports the engine of the network. With my skills, discipline, and passion for community living,
Hello, participants. Can someone talk so that I will know I'm audible? We had an issue.
Yes,
Okay. Okay.
Yeah,
Okay. We had an issue with the internet. Okay, so I was discussing, I said, when we are talking about the burden of neck pain, especially when you are discussing with your patients or you are reporting data, you don't only report the treatment costs, because it may be cheap to just give the treatment, but for the cost of transporting the patient to where the patient receives the intervention is part of the costs, and also what the patient is going to lose because of the condition. Probably the patient is doing some business, some side hustles, is a trader. So the period that patient is going to be absent from his own business, what is expected of that person to have earned within that period that that patient is absent? So all those things need to be taken into consideration before we say this is the economic burden of the condition. So neck pain has serious economic burden when all these things are taken into consideration. So there are certain risk factors for the development of neck pain, because those that develop neck pain, certain amount of them may develop into the chronic neck pain. So advanced age, usually younger individuals hardly develop neck pain. There may be some cases here and there, but people that have had their age getting advanced, they develop neck pain more than those that are younger. Being a female is a risk factor. Then low social support. So those with lower socioeconomic status are usually more at risk of developing neck pain than those that have high socioeconomic status. Then a previous history of neck or lower back pain, then another episode is a possibility. So this is another risk factor. But we should note that the risks are for acute development, but there is a tendency for neck pain to become a chronic one. We need to revise the anatomy, but I have to also caution here that when we are dealing with chronic neck pain, many of our colleagues, when patient comes in and the patient is reporting that he or she has pain that has lasted for 4 months, 5 months, the pain is not getting better. Many of us, the first thing that comes into our mind is what is wrong with the anatomical structures. Is there displacement? Is there degeneration? Is there a tear? Is there this? Is there this? But in the management of chronic spinal pain, this should be the last thing in our mind. Where we talk about the anatomy, most of the cases is, let's see if there are red flags that we should not manage this patient because of serious things we need to refer. But if such things are excluded, so most of those patients, their pain is not associated with the structures. It's mostly associated with the pain processing system. So the system has some issues. We are going to discuss that. But still, we need to take into consideration these structures, because when we come to now observe and examine our patients, we need to make some certain movements. So if maybe some certain movements are contraindicated, maybe because of the red flags or other things, we need to know. So we need to know the integrity of these structures. And if there is also chronic pain that may not be associated with the structures, but because of its persistence, then these structures may be affected. Muscles may be weak because of inactivity. So we need to examine and see, probably maybe there is weakness, but is the weakness the causative factor for the pain, or is the pain that makes the muscles weak? So we have to know which is causing which. The same thing with the ligaments. Because of the inactivity, the ligaments may be lax, and then the joints may have instability. You lack protection of the joints, then there may be fear. So is it because the ligaments are already weak earlier than the pain and they cause the pain? Or is it because now the pain has been persisting and the individual has not been using the joints, and then the joints are getting weak and the ligaments are also getting weak? So we need to know this. So these structures, they provide protection, but they give protection when they are active. So if the patient is not using these structures, then they may not give the protection. And then you may now, in your assessment of the functions, you will see that the protection is not being given. And now it is only when maybe the pain is adequately handled, then the patient will be able to actively use the structures and provide the protection. The support of other structures also has to do with that. Then the passages, this has to do with the structures, the esophagus, the trachea that pass through the neck. So we need to see if there are issues related with them while examining the patient with neck pain. Then for individuals with chronic neck pain, in the acute neck pain, we hardly talk about psychosocial issues because psychosocial issues, usually they come if pain persists over time. It's not disappearing. And then it brings about other thoughts, other issues with the family. So in patients with chronic neck pain, we need to also take into consideration other things that have to do with the psychosocial life of the individuals. One, fear avoidance. Some individuals, when they have persistent neck pain, then this neck pain will now lead to fear avoidance among the sufferers, where they will now be afraid of doing activities or assuming certain positions with the thought that this may cause them to have pain or may worsen the pain they have. So because of this fear, an individual may not be walking, an individual may always be lying down, an individual may detest certain activities, thinking these activities are going to worsen his pain or are going to make pain to surface. But this is less common in acute neck pain. Then kinesiophobia, which is also related with the fear avoidance, but this one is to the certain region where you have fear of movement. There is pain in the neck, you are afraid of flexing, you are afraid of extending, you are afraid of side flexing or rotating the neck. So we need to all have this. If this is not assessed as part of the things you do as a musculoskeletal physiotherapist managing patient with chronic neck pain, you only see pain, you want to handle the pain. You give the patient some exercises, you say, do this, so number of times, so number of days. You discharge the patient. The patient may not do them because the patient still have the fear and you have not addressed the fear. And usually this fear is not addressed by the exercises. It is addressed by other psychosocial. Some individuals also may, because of the chronic neck pain they have, they magnify the pain, or they think the injury they have is very serious. They think probably maybe the bone has shattered, the spinal cord is too much compressed, they may end up with paralysis. So they may magnify their injury beyond the normal presentation of the condition. They may also present with helplessness. They think their situation is not something that can be resolved. They will feel helpless. They may be ruminating on worst scenarios. They'll be Mr. Y, Mr. This, Mr. Y, Mr. X, allergy M. They had something like this, and from that, they have never got the chance to get out and move again. So they may be associated with all these catastrophizing domains. And if we are handling our patients with chronic neck pain, we haven't assessed this, we may also leave something serious that may not allow our patients to get better. Probably you have seen from the evidence they said exercise is beneficial in the management of chronic neck pain. You have been giving them the exercise and you say the patients are not getting better. And you start blaming evidence that they said this is beneficial, but your patient is not getting better. Probably is because you have not assessed the patient as a whole, and some other psychosocial issues are there associated with the patient. You have not handled these issues, and then the patient will not get the desired result from the intervention you are given. So we need to pay much attention into this. Then education. We are going to discuss from the evidence. Many of our colleagues, when we see our patients, I will categorize our colleagues into three. Some of our colleagues, they don't educate the patients at all. So you see the patient has serious chronic neck pain has been persistent for months. So this is what you know to help the patient with chronic neck pain. You give them the exercise, maybe you manipulate, or you do whatever you want to do. You ask the patient to be doing, and that's all. So this are a group of therapists that don't educate the patients at all. Then the second group, we have certain colleagues. They will educate the patients, but they will only educate the patients biologically. You see, the reason why you have this pain that has persisted for this, I have looked at your X-ray. There are signs of aging in your X-ray. There are degenerations. There are osteophytes. These are medical terms. You may not understand them. You can see them here. They are the ones here. So all these are going to contribute to the fear of the patients. And some of those patients can only believe that they are going to get better if in the future you have also shown them X-ray to show that these degenerations have started disappearing. Because to them, it is those changes that makes them to have pain. And only sign of improvement is for those changes to start getting better. So this is the second category of our colleagues. They educate the patient, but they only use the biology. So they are trying to convince the patient that it is only when something is biologically wrong with your body that you will have this pain persisting for long. Then the third category, which I believe are the minority, are the ones that will educate the patient, but they will use biopsychosocial model of educating the patient. You see, yes, you have pain that has persisted for long. Under normal circumstances, during the early days of pain, pain serves a purpose of protection and informing you about potential injury or an injury that you need to handle. And this pain should disappear when that injury is no more, when that threat is no more, when that fear is no more, or when the injury has healed. If the injury has healed or the fear is no more and this pain persists for more than so period, then probably the system that takes the messages of fear, injury to your brain and interpret it as pain so that you draw attention of yourself and seek medical attention is probably faulty. So probably there is no injury, but the method in which these messages are delivered to the brain are getting faulty. So we need to work on how your messages will be improved. And then if there is no fear, the messages shouldn't reach the brain and the brain should not interpret that you should have pain. And even give some examples where individuals that do not have injuries, they may end up with pain. Individuals that have injuries, they may not have pain. Or individuals with serious injuries have less pain. Or individuals with minor injuries have serious pain. So that you will now de-emphasize injury as the only explanation to having pain. So educating the patient, knowing the level of the education of the patient, asking the patient, okay, what do you think is wrong with you? I think I have serious injury in the spine. Maybe my bone has shifted, maybe this, maybe this. If this is what the patient think is the problem, then till when you educate the patient and change the narration for the patient and the patient is convinced, it is only then that your patient may get the desired results. Then beliefs also. We need to also assess if there are certain beliefs culturally in this part of the world, probably, maybe some of the beliefs, they are just coming to the hospital, but they still believe maybe because they have succeeded in their business or in their workplace. That is why they are in this serious pain, and they will think there are all those spiritual aspects related to the pain. Maybe a business partner, a work partner have done something to make sure that they are brought down. So if you have not also assessed these kind of beliefs to see if there are abnormal beliefs associated with your patient that has chronic pain, neck pain or not, then you may not handle the patient appropriately. Then depression. You need to also see, as a result of this pain that has been persisting for the patient for all this long time, is the patient depressed? The patient might probably be depressed, but you have not assessed. And there are also recommended interventions that you should give if the patient is depressed. But you are only given those that have been recommended for someone that has pure chronic neck pain without associated disorders. And then probably maybe the patient is not getting better because you have not assessed this aspect of the patient. So all this need to be part of the things that we should put in our mind when we are handling patients with chronic spinal pain, specifically in this our presentation, chronic neck pain. All this can be possible, can be associated with the patient, and if they exist, then there are recommended ways that we should handle our patient with such presentations. So why is your patient in pain? When a clinician sees a patient with neck pain, the first thought will probably be, is there an underlying sinister cause of this patient's neck pain? This should be common in acute neck pain presentation. In chronic case, I think we should need to brainstorm here with few of our colleagues, maybe bring in some inputs here when they see their patients with chronic neck pain. This introductory aspect I discussed, don't use them to explain the scenarios for us now, because we are having the workshop to now learn. From your practice, when a patient comes with chronic neck pain, what are you trying to do? Are you trying to diagnose? What are you trying to diagnose? Can we have some of our colleagues giving some inputs here? Participants.
Okay, sometimes in my case, when I see patients that have chronic neck pain, am I audible?
Yes. Yes, you
Okay.
are.
Yeah, I try to find out the nature of their work and take a look at what kind of ergonomics they have like at work and what they've been exposed to. Some will be like they've been having it for some time. Sometimes it's like acute upon chronic exacerbation. So I'm going to ask if the patient do a lot of, there are some patients that they tell you they work in the market. So I try to delve more into the history to get what kind of experiences they've been through, what they've exposed the neck to. Maybe they lift something heavy on the head or the likes like that. So those are one of the things I kind of look for first from the history, and then I check examination, like the muscles around the neck too.
Okay, I will respond to this. I have noted it down. Yes, from other participants, please, when patient comes to you with persistent pain in the neck region for more than 3 months, what comes to your mind when you are assessing the patient? Dr. Abimbola have responded. I want to know from others.
Hello, good afternoon, sir.
Yes, good afternoon, Dr. Peace.
Yes, sir. So I'm going to give example with a patient I'm seeing recently. She is
Okay.
79 years old. When she
Okay.
came to me for the first time,
Okay.
after assessing her, she
Yes.
said she's been having the pain for more than 6 months. She has gone to various orthopedic doctors, and she has been on different medications, and it's not getting better.
Okay.
So what I noticed from assessing her physical examination was that she has this kyphotic posture, and
Okay.
then active range of motion. Like I asked her to flex, extend, a side flexion, rotate the neck. She wasn't able to do much. Like the neck was basically stiff, very stiff. Like
Okay.
the range of motion was very limited.
Okay.
And her upper trapezius, upper part of her back were not
Okay.
just stiff, they were like in spasm. And then
Okay.
also she mentioned that many times, maybe because she was on so many medications, many times when she's lying down at night, she feels better, but during the day she gets up to do anything. She has so
Okay.
much pain, she cannot, continue basic ADLs. So
Okay.
yeah. So that's the main thing. For me, the main thing was that I was concerned for is the fact that she's not able to move that neck properly. Like she's not
Okay.
able to rotate. It was really, really stiff, and that was
Okay.
the main thing I started working on. So yeah,
Okay.
I'm giving this as an example. Yeah.
Okay. This is interesting. Okay. Can we get another individual?
Yes, sir. Good afternoon,
Okay.
sir.
Yes, good afternoon, Dr. Suleiman.
Yes, sir. Sir, as you said, when a patient came with a neck pain for more than 3 months, what
Yes.
came to my mind? Okay, sir, I will think of like 2 or 3 things. Maybe cervical issue related to like discs, maybe the intervertebral discs. Then number 2, arthritis, maybe degenerative changes, or any
Okay.
other inflammatory conditions like
Okay.
that.
Okay.
This
Thank
is
you
what
very
I
much. Yes. Who else, please?
Good afternoon,
Dr.
sir.
Umar. Yes, good
Yes, sir.
afternoon.
Sir, relates to the patient that presents to me with chronic pain of more than 3 months.
In the neck
I
region.
will actually neck region, yes, sir. Actually,
Yes.
having gone through all the physical examinations and everything, I will then start asking questions, the work-related questions.
Okay. Those
Whether
physical examinations you will do.
Yes, sir.
Are you going to do them with the sole intention of finding what is wrong with the neck? Why this patient has this persistent neck pain? So you are trying to find the reason why this pain is there, or it is for a different reason that you will examine the neck?
No, it's for the same reason. It's for
Trying
the
to
same
find the
reason.
fault. Trying to find
Yes,
the
sir.
fault? Okay.
Yes, sir. If there is any anatomical deficits,
okay,
I've been looking at the radiological investigations, trying to figure out anatomical deficits. If there is none, then I will relate the pain to I will relate it to work-related musculoskeletal disorder. Is the patient doing something out there that may actually predispose him to such a chronic pain? Is he involved in lifting a heavy weight? Where is the patient working? Where is the patient working? That's the first thing.
Okay.
How is the nature of his work? What is he doing at home? These are the things that I would put into consideration, sir.
Okay. Do we have another person?
Yes, sir. Good afternoon.
Yes, good afternoon.
So the first, as you asked about what comes to our mind when the patient came with neck pain lasting more than 3 months.
Yes.
The first thing I usually do after physical examination, like assessing the neck range of motion,
Okay.
finding and also asking the patient the nature of his work and the ergonomics. Maybe that patient is spending more time on screen, laptop.
Okay.
Hello, sir.
I am
And
listening
also,
now.
okay. And sometimes depend when I'm moving down to the upper limbs, I also assess the myotomes and dermatomes.
Okay.
Yes. Good morning once again, sir.
Yes, Abakar Yahya.
Yes, sir. Yes, I know. And the first thing I would do when a patient with chronic neck pain comes to a clinic is that I will first consider his age, and then I will also consider his the nature of his work, and then I will also look for previous history of injury.
Okay. Yes.
Continue, Dr. Bakari Yahya Musa.
That's all. I'm done, sir. Sir, can you hear me?
Okay, that's all. Yes, now I can hear you. Yes. Are we together? Can you hear me?
Yes, sir. We can hear you.
Okay.
Yes, sir. We can
I'm
hear
getting
you.
feedbacks. Dr. Festus, you want to talk?
Good morning, sir.
Yes, good morning, Dr. Enahoro.
Yes, sir. Thank you very much. As for me,
Okay.
seeing this kind of chronic patient for the first time, some of the things I will try to look for is, because aside knowing from my subjective examination, aside knowing the age of the patient, the kind of occupation he or she has done, I will also try to get to know from the radiological investigation what medication this patient has been on since and what kind of management this patient has gone through. And I will also try to know if there are any red flags for me to know if it's a condition I can manage under myself, or I'll have to refer this patient for further investigation, because we've had so many misdiagnoses that at the end of the day, it will break down the patient. Even my own treatment may bring some negative results to the patient. So I'll try to know all this information first before doing any further intervention. Thank you.
Yes, that is interesting. Okay. Who else, please? Or I should respond.
Hello, sir.
Yes.
So whenever I have patient with neck pain, after taking chief complaint,
Not just neck pain. We are talking about the patient presenting with pain that has been persisting for 3 months or above.
Okay. After taking history, I will go on to ask about the what aggravates the pain? Or is there any movement that aggravates the pain? Or what he does to alleviate the pain? And also, I will proceed on asking, what is the effect of the pain on his activity? Does it limit some of his activity or not? Then I will go further on to ask about 24 hours pattern of the pain. How does the pain come? Is it in the morning?
These are part of the characteristics of the pain. So we were asking, what will you be interested in looking at as maybe why this patient is having this pain?
Okay, I will go on to ask about his occupation and his lifestyle.
So you may relate it with occupation lifestyle. Okay.
Yes, sir.
Okay. So I think we have gotten enough feedbacks. So I think I should respond to some or all. So I think we started with Dr. Abimbola, and the emphasis were on the ergonomics of the individual, how the patient does his usual work or occupation. This is very relevant in most of the cases when patient presents with acute pain. Patient presenting with acute pain, okay. Has he assumed an abnormal posture that is unusual? Because the patient must have been either maybe doing that occupation for years. If there is something you have been doing for years and has not been giving you symptoms, then your body is used to it and it is normal for the body. Even if ergonomically someone will say that thing is not ideal, our body can adapt to different positions. That is why there is no rigid rule of how you sit or how you lie down or how you... If your body is so flexible and adaptive to that, and you have done it for a very long time without any symptoms, then your body has adapted to it. So if anything happened from such position in the recent time, then this is an acute pain. Then you can now check if there is any change in posture, change in the position, or something has happened. That is what very long time, 3 months or above. It is, in most of the cases, not related to the posture or the ergonomics. Because at the first initial time, usually, if it is related to the posture of the ergonomics, the patients on their own, they will notice. As soon as they assume the position they expect, then they avoid it. That is at the acute stage. But as it goes over time for 1 month, 2 months, 3 months, then other things psychosocially may come and complicate the issue. So even if there are things that you may address ergonomically, you need to go beyond the ergonomics. The patient is now afraid, doesn't want to even move the neck, doesn't want to even go to his job. If he's a weightlifter, will now relate the work with weightlifting, and then now he's not getting more money, he's not doing the weightlifting again, he's not doing this, then a lot of things may come and complicate the case. So if we also don't go to this extent, then we may not know the actual thing that is making the pain to persist for a very long time. So relating it to only ergonomics is like we are still making it purely biological, that there are no other psychosocial factors that may make this pain to persist for all this long. So we need to broaden our minds when coming across this kind of patients. Dr. Peace, you brought an interesting case of an old person that has had pain persisting for many months. The patient you said is having kyphotic posture, there are stiffness, there are spasms. So in this case, when patient is presenting with this kind of things, even though the pain has been there for a very long time, then it gives some hint that you should examine to make sure that there are no other systemic diseases and there are no red flags. I'm not sure if maybe that your patient has been screened and investigated for ankylosing spondylitis. Maybe there is something related to that. There are other systemic disease investigated. If these have been investigated and they are not existing, then other psychosocial assessments need to be there. How is the social support where she lives? Is anybody taking care of her? Probably maybe there were some investigations that have been written, go for MRI, go for CT scan, go for this, will handle those things. So all those worries have been part of the problem. Now she's afraid that probably maybe this condition will be what will take her to her grave because nobody is going to assist her. She can't afford the investigations. She can't. So all these psychosocial issues need to be also adequately investigated. Dr. Suleiman, you gave issues with the disc, with arthritis, with inflammation. So you can see patient presenting to you with pain that has lasted for many months, but you are still thinking any biological thing that is making the patient to have pain. And in chronic presentation, there may be biological reason and there may be psychosocial reasons. And by the time you look through and you see in the x-ray there are signs of degeneration, you will end up telling the patient, okay, it is arthritis you have, and from the evidence, it should be managed, and you manage the patient and the patient goes. But you have not handled those psychosocial issues. Maybe there are even fears, there are avoidance, there are catastrophizing, and this patient may not do the exercises you give because he is afraid. If you want to give manipulative therapy, the patient will have fear, palpitations, that his spine can get fractured, can get this, because the patient is in fear. You that is expecting the patient to get better after that, the patient will only be happy that you have removed your hands from the spine. Now he should have a relief of that fear that you will break his spine. So all these things need to also be investigated. There may be patients that don't have the fear, don't have the catastrophizing, but you will not be sure if you have not screened them. So only the screening will now tell you that, yes, I should do this, I should not do this. Dr. Umar Ahmad is also thinking in the same direction, trying to find the faults. Maybe it is work-related musculoskeletal disorders. And I said, it is understandable when patients present with pain in the last 1 day, 1 week, 1 month, 6 weeks, to relate it easily with what they did, because what they did can pose a threat to them and the body will react that you have done something abnormal, and the body will now react and the brain will send signals that there should be pain so that you should protect the area so that you will not get more injuries. But if it lasts for more than 3 months, it is not usually the physiological way, because if the fear is not there, the threat is not there, then the body should act and behave normally and you shouldn't have pain. So we need to have this when we are thinking and handling our patients. Dr. Neaya is also thinking of the ergonomics. It's not bad you think of the ergonomics, but you should also think other things may be associated with the pain, not the ergonomics. Where if you actually, many of the patients I handle, after educating them and assessing this, screening them, explaining this to them, sometimes without even giving them interventions, within a few days, they will tell you they are getting better because now they are educated, the fear is disappearing. Those things are normal part of their problems. Dr. Enahoro, Dr. Abakar is also thinking of the nature of the work, so has to do with the ergonomics. Dr. Enahoro, thinking about the radiology. In the introduction, I have also mentioned sometimes 2 plain x-rays of individuals may be brought to you. One is in serious spinal pain, maybe in the neck. While the person that has serious pain, there are no signs of degeneration there, no disc herniation, but it's in serious pain. So in that case, how would you relate with the x-rays? So that is why we said in chronic conditions, it is wrong when your patient, probably before coming to you, has already passed through a radiological center, got an x-ray, and even brought the x-ray to you. And before you even clerk the patient, assess the patient, you look at the x-ray. It's very wrong. When you do that, you are already thinking in only the biological way. If probably that patient picked a wrong x-ray brought to you, you will still use that x-ray to explain the problem of the patient. So we have to be careful with how we look at radiological investigations. Usually they should come in our clerking. We have also been emphasizing that you look at them at the end, after you have so many hypotheses in your mind. But if you look at the x-ray first, even the investigations you will do, the physical examination you will do, is in relation with what you saw in the x-ray. So you will limit your thinking to only the biology there. So we have to be careful with what we do that in that case. Dr. Muhammad is also talking about provocative tests, still thinking about biology. Maybe there is compression, there is this, the lifestyle, the occupation. It is still not bad, I said, when you also screen those things. But basing your own diagnosis towards that is what will now give a serious issue to how you actually diagnose the patient and how you handle the patient. So at this stage, I have to now mention that in acute neck pain, most of your patients, you have something to point at to say this is the reason why your patient has pain. But in chronic spinal pain, 90–80% of the patients, we term them as non-specific. There is no specific biological fault that we can see is the reason why the patient is having that pain. So if most of these, our colleagues that have responded are thinking in the biological aspect, meaning that most of the chronic pain patients that come to our clinic, we always think of a biological reason why they have pain in the neck persisting. When actually 9 out of 10 patients that have, or 8 out of 10 patients, or 7 out of 10 patients that have persistent pain in the neck region, there is no biological reason that you can actually is causing their pain. It's probably because the system managing and handling the messages that go to the brain, the ascending tract, and then the descending tract on how messages are sent from the brain down to the periphery to tell you either to be in pain because there is fear, there is danger, is faulty. That is why probably the patients are having pain persisting for all that long. So we need to take this into consideration. It is good that we brainstormed and it has increased some of the things I want to explain. So for the anatomy, yes, we know there are muscles, there are bones, there are joints, there are ligaments. So we have the skeletal aspect, we have the soft tissue aspect. We need to know them for sure. For the muscles, yes, we expect the muscles to move the segments of the body. If there are weakness of the muscles, while assessing the patient, we need to document that there are weakness of the muscle. At the end, we will know the reason why there is weakness. Maybe there were fear and inactivity. So it's not the pain that makes, it's not the weakness that makes the pain, it is the pain that makes the weakness. So now, as we now handle the reason. Okay, why are you not moving your neck? I am afraid when I move the neck will feel like it's going to fall down. That is why I am having this. So you now handle the fear. So how am I going to handle the fear of the patient? So you now use the interventions that are found to be beneficial in handling the fear of the patient. So if there are fear avoidance or something like that. Also, we need to know the anatomy also very well. There are certain vessels. So that when we are now examining our patients, if there are, for example, some vascular insufficiencies, so you can adequately protect the patient from getting those vascular bundles getting compressed. Or if at the end there are evidence that in managing chronic neck pain patients, maybe some certain mobilization and manipulations are carried out so that you will safely administer them. So you need to also examine the, you need to have at your fingertips the anatomical structures around the neck region, and then you go ahead. But always thinking that these biological structures are the reason for the pain is most of the times faulty. So we examine them because we want to relate them with either the diagnosis of our patient or how we manage the patient or the reason why these structures are also having some faults. So I'm not going to dwell more on the structures because in the chronic neck pain, I said in most of the cases, it is not the biology, but the biology might at the end be affected because some psychosocial components have contributed and worsened the scenario, and then the patient may be having such. So possible causes of pain in the neck region and or limitation of movement in the neck region. So I mentioned there are usually a few etiological. So few reasons may be why the patient is having persistent neck pain. For example, yes, compression. It may be the nerve roots have been persistently compressed. Then the patient may be having symptoms and probably with radiculopathy for a very long time. So this is purely a biological reason. But if it persists for up to 3 months and above, it may also be associated with psychosocial issues. Probably now the patient is afraid to move the upper limbs, is afraid to do this, is thinking that he's not going to recover completely. Someone has told him that spine at the cervical region, if there are compressions, they may end up with even paralysis of the lower limbs. So fear, catastrophization, and other things might have been also associated with it. So they are maybe etiological. So in that case, probably there are compressions. Then what are the interventions that have been found to be effective in decompressing the patient? Then we may give them. But if we limit ourselves to only the etiology, then it means it is only those interventions that are meant to relieve radiculopathy that will be given. But if you have adequately assessed the patient, probably maybe there are those psychosocial components. So you will now also administer interventions that address psychosocial symptoms so that you will now handle the patient as a whole. So etiological is the minority of the reasons for your patient to have chronic neck pain. Then most of the chronic neck pain are as a result of maladaptation and malfunctioning of the pain processing system. I will talk a little about this. Physiologically, our brain is built up in such a way that impulses, messages are sent to the brain. And along the way, there are receiving mechanisms where some impulses don't need to even reach the brain. Then they will be blocked because there are no threats for them to reach the brain. So if someone touches you, it is just a touch, it's not something injurious, then the message will be stopped. There are no threats. If someone will bite, then the message will be sent and then the brain will interpret that there is a danger. And then you will feel pain. And then if such danger or the injury healed, maybe there is a little distortion of the soft tissue, the muscles. After a few days, the injury is no more there. Even if you move the neck, you won't feel pain because the impulses will not be that serious to reach the brain, and then the brain will not interpret that you are in danger, and then you will not feel pain. But in chronic neck pain, sometimes these impulses, there is the initial reason why someone had the pain at the early stage, maybe abnormal posture during sleeping or looking at the laptop, or a mild accident or trauma. At that time, yes, there was a reason for fear of injury, or an injury was even there. So that was why there were impulses, there were messages sent to the brain, and the brain interpreted that, yes, there is a threat, there is an injury, there should be pain. You need to take a measure. You need to protect yourself. But when this threat is no more, or the injury has healed, under normal circumstances, the brain shouldn't be sending descending impulses, messages that there should be pain. When the messages reach there, it will not be interpreted as a threat. There is no threat. Then it is something normal, then no pain. But if this system becomes hypersensitive, the sieving mechanism where little impulses shouldn't be even allowed to reach the brain, they should be blocked because they are not significant. Now the system is faulty. So little impulses are continuously allowed to reach the brain. And then the brain have become hyperactive and then will always be sending back impulses. Little movement, oh, there is danger, there should be pain. Little fear, there should be danger, there should be pain. So then the system is now faulty. So the system is maladapting, and then the system will be putting the patient, the sufferer, in pain persistently. So this is often a case in chronic neck pain patients. So let's go now to the subjective examination. It makes sense that when you have the patient, you now ask them if they can clearly pinpoint where in their body they have the pain and where they think the pain runs to, or it is only limited to a certain position. If there is a certain position, it is good in the clinic if you have the pictures of both the body charts. We hardly do this in our clinical practice. We always complain maybe because of the workload or whatever, but it is still better if maybe in the clerking sheets we have this. So you only pinpoint where and where your patient has the pain. So that when you are managing the patient, maybe if the area has decreased during review, the patient is now only pointing to a little area, while previously maybe there are extensive areas where the patient shows that he or she has the pain. It means the pain the patient is having is improving. But if we haven't done this, then it will be difficult. And as part of continuation of treatment, maybe you are not the one to also continue managing the patient. Someone that came will now see previously this is the level, and currently this is where we are. Also, if the pain of the patient is worsening, you will also see initially this is only the little area where the patient described, and now the pain is spreading over extensive area. So it is good that if we use the body chart to know where the patient has the pain. So we need to also get the perception of the patient's attitude and feelings. If we know the gender, elderly people, the fear, thinking that it is the age changes that have come to stay with them, it will not disappear, we need to know. So if it's a younger individual, thinking that maybe this is going to affect his career, many things that he wants to achieve in life, this is tying him down, we need to know this. Then the gender, some of the attitudes we have also may be related with the gender. Someone that is in persistent pain and is the head of the family, has to supply for the family, and this pain is affecting the occupation of the patient, cannot cater for the family adequately. Probably maybe there are some serious issues in the family. We need to know this and address this ethnicity. There are some varying things with ethnic and cultural backgrounds because of the expectations in the culture. Where they have adequate social support, maybe the worries may not be much. That it is usually common that when someone is having this or has not gone to the market, usually the family or friends or whatever can easily supply some things. Oh, you have not been coming to the market, that's why we supply this. So it may be part of the social supports that may make someone's presentation less, and the fear and the worries may be less. While in some places where maybe the culture is not so helpful, the social background is not like that, you either provide for your family or your family are on their own. So we need to go to such extent when pain is becoming chronic to know how it affects someone's attitude and feelings. Also the occupation, how someone is able to now go to work, is able to do all what is expected, or is already losing customers because of some of those things. Maybe if it is an occupation where maybe there are competitions and immediately maybe someone is said to be sick, maybe others will think you cannot discharge the responsibility a lot. You will start losing customers, and then the patient is already afraid, is having fear. So we need to go to that extent and have such discussion with the patient. So for the area of the current symptoms, we have to be exact when mapping out the area of the symptoms. So that is why using the chart is very beneficial, because in the chart, usually you can even ask the patient, okay, can you just maybe using this picture describe, or you just draw with your pen, the areas you are having your pain. So instead of us just documenting pain in the upper cervical region or pain in the right neck region, something like that. So it is good to have the mapping of that. Patient with upper cervical spine disorders, usually they have pain that high up around the occiput and pain over the head and over the face. So it may give some radiations, maybe to the head, to the face. So screening and asking our patients if they have maybe neck pain with associated headache or facial symptoms, we need to check for that. We need to also ascertain the worst symptoms and record where the patient feels the symptoms are coming from. If they think their pain is coming from somewhere and it has no relationship with that, it will give us an idea that we need to now educate this patient and change maybe some attitudes that the patient has already developed. Maybe there are some maladaptations. So even though in chronic neck pain patients, it might not be with pure biological reasons, but we still need to check the head. We need to check if there are symptoms in the teeth, temporomandibular joints, the thoracic spine, the shoulder, elbow, wrist, if maybe there are radiculopathy or not. Then if there are signs of maybe vascular bundle dysfunctions, maybe disequilibrium, dizziness, as part of the chronic presentation of our patient. So now, the patient is having pain, then we need to assess the quality of the pain. If there is headache, we need to check if there is blurred vision, loss of balance, tinnitus, auditory disturbance. So all this we need to investigate to see if there are other systemic presentations. Because even though maybe there may not be biological reasons why we said fewer percentage of the chronic neck pain, they may be associated with other maybe systemic diseases or some biological problems with the spine. Intensity of the pain, I think maybe recently we now use outcome measure to now rate the intensity of the pain, which is the ideal thing, so that we will know if the patient's pain is so severe or is mild. Sometimes the patient's pain, you will see it is a mild pain, but they are still disturbed about it. And at that time, probably it is an outcome where, in an ideal sense, the pain scoring, if a patient has that level of pain, less to reduce the pain intensity because the pain intensity is already mild. But the patient's perception and other associated fear and psychological issues might have been the ones worsening and making the patient to worry more. So that is why you need to now assess the pain intensity and then relate it with how serious the patients are thinking of their condition. A patient with mild pain and still getting worried has obviously psychosocial component that you need to address. Maybe when you now explain to him or her, the fear will start disappearing, and then the patient will now consider himself as someone healthy. The depth of the pain, if they think it is down inside their spinal cord or something, abnormal sensations, maybe there are some psychological things that they will be feeling. The pain is here, it's there, it's jumping from here to here. All those things need to be adequately documented. Is the patient's pain constant or intermittent? It is very hard to have a constant chronic neck pain for all 3 months and above. If it exists, it is calling for a red flag. Probably maybe there are issues of neoplasm, maybe some cancer or something. So knowing when the patient has the pain and how serious the pain is will now also give you an idea that may help you in deciding that this patient needs to go for other investigations. It is a red flag, or this is not something very serious that need to go for such investigations. It may be something that we can easily manage in physiotherapy. Then the relationship of symptoms, the pain and some other activities. Maybe when the patient does something, then the pain gets better. When the patient does something, the pain gets worse. It will guide you to know if maybe there are biological structures still, because as the patient does something, maybe it gets worse, which structures are implicated. It also will guide you in managing the patient. If there are some exercises, some manipulations that you need to do, and these exercises will involve those movements that the patient think his or her pain gets worse, then you have to now counsel the patient and educate the patient before you now remove the fear that the pain is going to get worse, because they already know that this is something that may worsen their pain. The behaviors, so what movements and positions aggravate the patient's symptoms, as I have already explained in the previous slide. Is the patient able to maintain the position or movements of the severity? If the patient knows that this is an angle or certain position where the pain gets worse, immediately they reach that, they have to now move their neck away from that angle, meaning that there might be some biological reason, or they can be able to sustain that position, but they will be telling you, but I'm still having pain. This may be associated with some fear or psychological component. What happened to other symptoms when this symptom is produced or made worse, as I explained? So when this happens, what happens to the other symptoms? How long does the symptoms take to ease after the movement? Sometimes when the patient, you move and you now bring back the angle of the neck to a neutral position, there is no more pain. But some, when you move and you bring it to neutral, the pain will still persist and it will take some time before it gets better. Usually pain that still persists after the examination till after sometimes may be associated with biological structures, and individuals that immediately you now bring back the neck into neutral position, the pain is no more there. It might be associated with psychosocial component, the fear of moving the neck. Immediately you start moving the neck, the fear is there, then the impulses from the brain will now assume that there is a threat, you have to be in pain. Immediately that position is no more there, then the fear is no more there. So it's like there is a psychological component that is making the neck irritable. So how symptoms affect functions, their activities, and in static postures. You note the details and nature of training. If someone is the type that undergoes sports, and then if maybe they are dominant with some certain part of their limbs, maybe someone that is having right upper limb dominance, and then it is the right upper limb that is always having the symptoms when they move into some certain activities. Then erasing factors, we need to note them. Sometimes we have to utilize the positions that makes the pain better to start training our patients, to start treating our patients before we move to other positions that should be part of their life, but at the initial stage, they get their symptoms worse by assuming such positions. Movement and all positions that ease patient symptoms, we utilize them. Then part of the comments I get from the colleagues when we had the discussion, some they discuss about the 24-hour symptoms. So we need to know about this. The night symptoms, difficulty getting to sleep. Many of our colleagues that are managing patients with chronic neck pain or low back pain, they hardly discuss the issue of sleep. And from the evidence, if, for example, we have chronic neck pain with sleep disturbance, there are interventions that are recommended. And then chronic neck pain without sleep disturbance, there are interventions that are recommended. But we will now see maybe, yes, we give manipulation, we give this, we ask the patient to go. And probably in the components of the treatment, we give the patient sleep hygiene and interventions regarding sleep are not included. So we need to always ask if there are night symptoms and if they affect sleep or not. Anytime we see that it affects sleep, then we have to include intervention regarding sleep hygiene that are found to be beneficial. What position is comfortable and uncomfortable? You have to get this. Sometimes we have to consider also the patient's culture, religion, and what have you. Maybe the position they assume that is comfortable, that doesn't give them symptom, culturally is considered a bad posture. For example, in Hausa culture, and for those that are Muslims, lying prone on the stomach is discouraged, and probably maybe is the position of comfort. So now the patient will be able to sleep, but is still having the worry that is doing something that is against the religion and something against the culture. So if you get to know these details, then you need to also work towards making the patient to have comfortable positions all around and removing some of such restrictions. Are the symptoms waking the patient from sleep, or is just that the sleep is not the type they want to have? If the patient is having maybe change in mattresses, change in pillows over this period of time, you need to see the adaptations. If maybe the patient is using a pillow, you ask, okay, if you remove the pillow, what happens when you sleep? If you add a pillow, what happens when you sleep? If probably with all these changes, you add a pillow, you remove a pillow, you change the position on the mattress, the condition is not changing, then you can clearly say it is not related to the ergonomics. We have changed all these things and it's not having any change with it. But if you now make some adjustments and there are symptom changes, then you will now relate it to the ergonomics. So by this, you can know if the biology is part of the issue or is not. Then for the morning symptoms, also the nature of the symptoms at early morning, through the day and end of the day, if there are some issues related to the stiffness in the morning, as it is suggested with some degenerative changes, we need to know this. So we need to ask special questions to identify certain precautions or contraindications to the physical examination and or treatment. So at this stage, when you get all this information, you will now know, are there things that are maybe probably red flags for me? So that I will just send the patient for other investigations first before I see. If after all this information, there are no indications that you should not touch the patient, then this is where you can now comfortably go ahead and examine the patient. Other things I have mentioned earlier, like the instability and vascular dysfunctions. If you suspect them, arterial dysfunction, you know there is possibility that there will be compression of the blood supply to the brain and anything can happen to the patient. So you need to be careful with the examination you do, and usually manipulation is discouraged. Or probably you have to even send the patient for other investigations. Upper cervical instability also, patients with instability, usually if you suspect that and you use other peripheral joints to examine if the patient is having instability or not, then now you should know, for example, manipulation. Under normal physiological range, manipulation will now give an increase in the range and you get a result. But in instability, you have no control on how much the angle of the movement will be. So someone with upper cervical instability, you now rule out examinations that have to do with manipulations and mobilizations. And in interventions, you also rule out such interventions. So now, for the history, you know it has started somewhere. But since it is chronic, but you still need to ask, okay, there was an injury, maybe a whiplash, there was an accident, and there was acceleration, deceleration impact to the neck. And at that time, there was investigation, there was this, there was this. But after that, maybe there is even a follow-up investigation. And in the follow-up, they told the patient that everything is now normal with the neck, but the patient is still having pain in the neck. If you now get the history very well, probably maybe you will now relate it with present situation. The patient is still having fear. Probably the patient has already decided will not even go for a long journey, is already hating to ride a car because of that. So you will now know that there are associated fears that might be aggravating the patient's pain. And at that time that the patient had the initial onset of the pain, was it sudden or slow onset? Sudden, probably maybe there was an injury, then you can now check if that injury has already healed or the injury has not been appropriately managed. If it is slow onset, probably maybe it is something that you cannot attribute to certain biological reason. Known or unknown cause that provoke the onset of the symptoms, like the issue of the slow onset, usually slow onset may not be related with something. Are there associated headache? If there are associated headache, there are evidence regarding neck pain that has associated headache, so that you will now give such interventions that are found to be beneficial to neck pain patients with associated headache. If there is no associated headache, then you go for interventions that are for patients without associated headache. Change in patient's lifestyle. Has anything changed over the time because of the pain? And is the patient happy with those changes, or is just a coping mechanism because of the pain persisting? I'm no longer doing this, I'm no longer doing this. But is it what you want to be doing now, or is just because of pain? You are even hoping that how this pain can disappear so that you will go back to the normal lifestyle. So we take also the relevant and past medical histories, if there were also surgeries, previous accidents. These ones we will now know if maybe they have affected other biological structures. Maybe because of the surgery, there are some certain limits to which the patient can move the neck, can rotate the neck. So that one will give you an idea on how you educate the patient. Because of this procedure done on the implant foot, then you will not be able to move to so-so range and so-so range. There are restrictions. So the patient has to know the limits to which they can expect their outcomes. Social history here, because of the biopsychosocial psychosocial component we mentioned, we need to know a lot about this. Their expectations, their family support, their economic strength, how much they can afford, Are there some taboos related to the condition with their place of work, with the family? What do they do to cope with this pain that has persisted for long? Is that coping strategy they are using having long-term effect if you allow them to use them consistently? All this need to be noted. So now plan for physical examination in chronic neck pain. So what is wrong with the patient? Many of us, we send for investigations very early and we look at them very early. I have discussed part of this, but we still need to have maybe a little brainstorming here. So by the explanations I give participants, how much relevant are radiological investigations and when should we look at those investigations? I will need some responses. Unmute yourself and then respond to us. In chronic neck pain, how relevant are radiological investigations? And when should we request for them and when should we use them?
Good afternoon, sir.
Yes, good afternoon, sir.
Yes, I think before I can request for a radiological investigation, I should have done some objective provocative tests, like the Apley test, done some provocative tests to see if there is a radicular pain to the upper limb. Is the pain causing weakness? Is he having paresthesia? So when I do some provocative tests, I'll be able, what provocative test is actually positive for it. So if I know all these tests, then I can go further in requesting for a radiological examination to buttress my diagnosis. Thank you.
Okay. Yes, any participants? Yes. Who else do we have? Participants, the question is, when will you request for images and how much will you use them or trust the results from imaging? We have many participants. I'm expecting inputs. I want to also learn from our colleagues.
Okay, good afternoon, sir.
Yes, good afternoon, sir.
Okay, concerning the question you asked,
yes,
the radiological investigation, for me, first of all, once I'm done with the subjective and objective assessments, and I've been able to ascertain maybe from the questions asked and answers given that maybe this is a soft tissue problem at the neck. Okay, maybe there's no radiculopathy or anything, it's just a localized pain, but it has been there for long, though it goes and comes. Maybe patient has certain movements they do that aggravates it. Then maybe I don't need to send the person for radiological investigation just yet. I might begin to manage the person according to the symptoms and the answers the person have given. Unless the patient keeps complaining of the pains, and then I find out that these psychosocial factors are not what is leading to the pain, then I can now try to send the person for radiological investigation to be able to find out if there's any other pain. Yes.
That is interesting.
Thank you.
Okay. Yes. Any more participants? Okay. So with these two inputs I got, Dr. Enauro, yes, if we investigate and probably maybe there are radiculopathy, and by provocative tests, maybe you think yes. Physically, if it is ideal in the guideline to request for X-rays. Progressing means initially the symptoms of the radiation maybe are localized, maybe in the just arm. Now they have progressed maybe to the elbow, to the forearm, maybe tingling now in the fingers. Then it means it is progressing. Probably there is a compression that the compression is progressing. But the symptom since from inception is localized maybe in the arm. And for all this long, it is in the arm, meaning probably it is a non-progressive compression. Then part of the evidence of assessing our patients is that it is only when something is highly indicated and necessary that you recommend, especially when it requires finances. So it means this is a patient that might not need the X-ray and can be managed. So no need for you to send for the X-ray. There are no signs of progression. There are no signs of spinal cord issue. Then you now go for what is the evidence of managing patient with chronic neck pain with radiculopathy, and then you administer the interventions. But if there are signs that are indicative of progression, then you need to have the investigation and see the level of the compression. And based on the evidence, if that level of compression require other interventions, fine. If it doesn't require the interventions, based on the evidence, at this level, you need to start, for example, with physiotherapy, unless if physiotherapy failed to give result after so time, then you refer to maybe the surgeon, then you follow the guideline, the protocol. The explanations also given by Dr. Ifeanyi Chukwu, very interesting ones. So you raised concern whether if it is a soft tissue issue. Usually, for patients that present with chronic neck pain lasting 3 months and above, we hardly find soft tissue as the reason for their neck pain. Usually soft tissue injuries, they are injuries to the muscles, to the nerves, to the ligaments, but they last few weeks and then they get better. If because of them, maybe they existed in the past, there was pain, and probably now they have healed, the patient is still having pain, then it is not a soft tissue injury. It is a chronic neck pain associated with other psychosocial, psychological probably disorders. Maybe there was a fear. Since from the injury, they were afraid to move the segments, they were afraid to turn, they were afraid to this. So we need to screen for those. So imaging should only be requested if there are high indications for the imaging. Then do we trust the images? We trust them usually if we have been able to clinically examine our patients before the imaging, and usually their results corroborate with our findings. For example, an X-ray may reveal there is narrowing of the intervertebral space. But throughout your examination, your patient has no symptoms of radiculopathy. Then in that case, this is a normal change in the X-ray, but there are no symptoms to relate with them. So it is misleading for you to now use that to explain the problem of the patient, because narrowing should present with symptoms of compression, but there are no symptoms of compression. So if that X-ray is now giving them the diagnosis, there is spondylosis, there is this, we have to be careful with how we explain it to the patient so that we don't instill fear in the patient. What did the X-ray show? It has shown some changes that usually happen with day-to-day life and activities. This will not be scary to the patient. But if you now say, oh, the X-ray is showing that there are narrowing down of your vertebra. What is narrowing down? Okay, your vertebra, the space that is normal is lost, is this. That will technically instill fear in the patient. And in chronic pain management, we are trying to avoid all the languages that will instill fear in the patient. So in that case, I will not trust the X-ray because it is not corroborating with my physical examination. Yes, there is narrowing, but healthy individuals can have narrowing. So that narrowing is not the reason why this patient is having the neck pain. But the patient is having narrowing more prominent in the right aspect of the spine. And there are radiculopathy on the right upper limb. I can easily corroborate. Yes. So now I will tell him, yes, probably there are some little reduction in the space where your nerves are exiting. And automatically the patient, okay, is it possible to reduce, to increase the spacing? Yes, we have some techniques that we can use, and probably the spacing may increase. And even if the space didn't increase, we have some exercises, because the impact is only if your muscles are weak. If your muscles are strong enough, then you will not have the impact because the weight of your head and the movements are carried out by the muscles. And then the muscles, if they are strong, they will not allow impact on this. All these are part of the things that you have to interact with the patient and corroborate with the findings from the imaging. So for the physical examination, we need to have our clinical reasoning that the possibility of the patient having biology as the reason is lesser than the possibility of the patient having this chronic pain without any attributable biology. So we have to have this at the back of our mind. So is this patient's condition suitable for me to manage as a PT from all the history that you have gotten? If there are issues of neurovascular bundle compressions, if there are issues of cervical instability that is serious, from all those histories that you have gotten and the information, you should have such suspicion and probably maybe refer the patient. If your answer is yes, is someone that you can easily manage, then you can now go ahead. The second question is the patient's condition neuromusculoskeletal condition that I may be able to help? Or is more of non-biological, which is psychosocial? So from all the history you have gotten, you will now have an idea. If from the symptoms, the history you got, there are questionable things with the biology, that is with the nerves, with the muscles, with the skeleton, then you need to adequately examine, and if there are needs, you need to have the radiological investigations. If there are no suspicions for that, then you need to adequately also examine the psychosocial aspect, screen, and see what is associated with this chronic pain the patient is having in the neck region. We need to observe some of the feedbacks we got previously to say the patient is having kyphosis, the patient is having this. When we observe and we see that, we should not outrightly assume that is the reason why the patient is having the pain. It might be the other way around, that because the patient is having the pain, that is why he or she is assuming this posture. So the fault of the pain lead to the abnormal posture, not abnormal posture leading to the pain. So we observe the posture, of course, the muscles, the soft tissues. Many a times when we now do physical examination over the structures that we examine, if there are biological issues, we can easily see. If there are psychological issues, we can easily see. There are some certain pressures of examination that only them should provoke pain. And in some of the patients, a mere touch will now make their pain to be aggravated, which is purely psychological, because under normal physiological status, such little touch should not send any threat to the tissues and should not provoke pain. So are there associated fears, avoidance, and hopelessness? From observation, you can see someone that is in serious fear or trying to avoid some movements or is looking hopeless. All this by observation, we may be able to deduct. So for manual examination, we have to make sure that there are precautions for us while examining the patient. The therapists have to assume appropriate postures for examining the patient so that they don't do harm to themselves. Then the patients also need to be adequately supported in the best position for examination so that they will not be afraid. And we shouldn't give the patients impressions that biological pulse are the reasons why they have this persistent pain. We have to build hopes. We should not erode their hopes. In many of these conditions that patient presents, usually is not that their bones or their muscles or their ligaments have issues. Sometimes it may be associated with how your body take message and send the message to the brain and how the message is processed. And sometimes it has to do with how you also believe what is wrong with you and how you behave and the other things that follow after this. So we need to communicate with our patients in this way. So if we think there are biological reasons, we have to check the range of motions and the quality of the movements. We need to check all those. Behavior of the pain through the range of the movements. If there are resistance, that probably may be due to some certain structures, or aggravation, if maybe there are biological reasons of maybe disc prolapse or associated things. We need to check that. Provocation of any muscle spasm, as we are examining, if there are still biological reasons, we can see that. But sometimes when we do all these physical examinations, we may notice that all the provocations of the symptoms we may see, we can easily relate them with psychology, with fear or avoidance of the patient. If we passively examine the intervertebral joints as part of the reasons for the examination, then we need to check the quantity and then the quality of the range of motion. If we are thinking biological reason is what is causing the pain, then we may go on for natural apophyseal glides for the patient to now make the movements, the gliding movements and the rotational movements, and we should document the quality of the movement or the range of the motion. If there are resistance, then the behavior and then the provocation. Because if there are biological reasons, then we may give also biological interventions like manipulation. Then where we have the resistance probably is now where you will now try to increase the range of motion gradually, for example, using the techniques of manipulation that have been found to improve outcomes. But if there are no biological reasons, then you may not go ahead and give biological interventions. So these are just some of the examinations that we may give to the spine. I'm sorry, let me take some water. If there are indications for such movements, I have already mentioned and warned that we go ahead for observation and examination after we must have screened and see that this is a patient that is fit for our management and interventions. If there are red flags, there are other reasons for insufficiencies, for instabilities. These examinations are harmful to patients with such conditions. We refer the patients for other investigations. So the snags also, the red flags, if from the history of our patients, there were a history of trauma, serious trauma, the accident and the patient lost consciousness, was admitted, all those things we need to document. Issue of tumor, issue of cancer, spinal cord compromise. There are adequate reasons that we can say the spinal cord is really affected, symptoms that are in both upper limbs and probably also going to the lower limbs. systemic diseases like previously who mentioned, I think Dr. Peace, that was mentioning that elderly woman. If there are ankylosing spondylitis, we need to screen, or inflammatory arthritis. And if there are, then we need to also refer the patients to appropriate personnel for other investigations. Then if pain has been persistent, unrelieving, we need to also note that probably maybe we have to send the patients for screening for neoplasm. If there are previous medical histories that are also indicative of us not adequately examining the neck without other investigations, maybe previous surgeries. If there are previous surgeries, we need to send for investigations or previous medical reports to see what was done, what is the limit to which we can examine the neck, what is the limit to which we can probably maybe mobilize or manipulate the neck. All these red flags need to be given attention to. Palpations for tender points and trigger points. Sometimes, because of the chronic neck pain that the patient is presenting with, then that pain may make the neck inactive and the patients may be too protective. And then there could be acute soft tissue pain associated with the chronic pain. So the patient has been having persistent neck pain for long. And because of that, the associated fear of movement, some postures are not assumed by the patient. So the muscles around the neck, the trapezius, are made to be tensed. The neck is made to be less mobile. And when you now examine the neck on palpation, those fibers of the trapezius, when you examine them, they are very tensed. There are associated spasm, and then there are associated tender points. So if you happen to get that, so it means the chronic neck pain have also led to the development of trigger points, and then this need to be palpated, and appropriate interventions for trigger points need to be included in the management of the patient. If there are indications for you to go for other blood tests to see if there are ongoing infections in the body, or electrodiagnostics for the nerves, if maybe the nerves have been compressed and you want to see if they still carry impulses, the nerve conduction tests, you can go ahead and request for them. If there are no indications for them, then no need for that. I have already mentioned that the imaging should be based on evidence. If there are indications for imaging, you can go for them. If there are no indications, fine. If your patient has already had images, the patient will, of course, bring those results to you. Always make sure that these results are checked after your own examinations. You check them at the end, then you correlate their findings, as I have explained earlier, with what you have obtained. If they are in agreement, then they are just confirming what you have investigated. If there are inconsistencies, if mostly what they report there are conditions that can exist without even symptoms, then focus on other psychosocial components to make sure that you screen your patient very well without associating the fear of the results of radiological investigations. The results from radiological investigations, mostly, they increase the fear of the patient. Okay, spinal cord is compressed. Patient will now be upright. Okay, they say spinal cord is the one that handles my hands, my legs. So it means if it continues to compress, it's going to have this and this. There are nerve compressions. Nerves also control my hands, control my legs. Or there are instability. Instability is an English word. Okay, so my spine is not stable. It means I should be careful. I should not run. I should not do this. I should not engage myself in this. I should not. So they will be too restrictive to the patient. So they instill many fears. So part of the things that we need to also handle with the patient. So after those things, then there are self-assessment and subjective measures where we have to now include. Sometimes what you now finish examining may not be adequate, but you may give something to the patient for the patient to respond which will now also contribute to you getting the actual problem of the patient so that you will adequately handle them. So there are instruments that we can give. We either administer them to the patient, or the patient will be able to administer them themselves. Maybe educated patients can read the questions, can respond to them. Then at the end, you now aggregate the scores they get and categorize them to have something or not to have something. So these instruments primarily deal with perceived pain. You can give them, okay, let them explain the level of their pain from the questions they have. The fear avoidance, we have the tools. The kinesiophobia, we have the tools. Pain education, we have. Perceived disability, what do they think they cannot be able to do? Their inability or ability to cope with the neck pain, inability or ability to function, and all healthcare utilization. We have different tools that from the history that you have obtained on the examination, you may think, I think this patient may be having fear. Okay, let me give a subjective tool to assess if he has fear or not. And if he has the fear, at which level? So that if he has that, then I can include interventions that address fear, and subsequently I can now check if the fear has improved or not. Subjective measures may provide useful evaluative information for determining the etiology of the pain. However, in chronic pain, they may help in understanding non-biological contributors to the persistent pain. That are the biopsychosocial components. They provide valuable insight into the impact of the pain. They can be used to monitor the change of the condition over time. Because if this is the level of the fear, maybe serious fear avoidance significantly. And now after some interventions, now it is getting better, you can see. They can be very helpful in establishing the patient's perceived functional deficits or psychosomatic status. What they think they cannot do. And then you can now see if you can make the patients to achieve such functions or not. Be useful for choice of appropriate and effective treatment for both clinicians and patients. So after seeing what has contributed to the development of the neck pain or has now worsened the neck pain, then it makes it easier for the clinicians and the patients to now choose appropriate interventions. Now you have neck pain. So the patient may just, okay, what is the intervention to reduce the pain? But now after this, they will now notice, okay, so it means I have a lot of fear. Yes, you have. So now we have to now work on your fear so that they will not think this intervention you are giving me, how is it related to my pain? Because I am here because of pain. So only if you have been able to establish to them that they also have this, they have this, they have this, which are not biological, is because of how they think, how they are afraid of something, then you will be able to now make them change from such status to a better status. To determine the real value of such questionnaires, therapists, practitioners should know about its reliability and validity, ability to now detect if it is for fear. Is it able to now detect the fear? And if it is used repeatedly, is it going to change or is going to be consistently giving you the same result? So you have to get in tools that have been tested to be reliable and to be valid in assessing that condition. So it's not every questionnaire you see that you should use. You have to check and see that the developers or the users have found those questionnaires to be reliable and to be valid. So this is an example of one of the questionnaires, Neurophysiology of Pain Questionnaire. It assesses the patient's perception of why they are in the pain and also their knowledge of pain development in the body. If at the end they score less, they don't know much about pain, the neurophysiology, how pain is generated in the body, then you need to educate them to improve their knowledge about pain, its relevance. Then at the end, they may have better outcomes. For example, the first question here, it is possible to have pain and not know about it. Is it true? Is it false? Is it undecided by the patient? When part of your body is injured, spatial pain receptors convey the pain message to your brain. Are they aware of this? True or false? Or they don't know, they are unaware, undecided? Pain only occurs when you are injured. I can see there are faults in the content of the text. When you are injured or at risk of being injured. So you will now know their perception. If they now know that pain only occurs if there is injury or they are at a risk of developing injury, so this, your patient, is only when you have attributed the pain to a certain injury. Okay, this is the reason why you are in pain. They will believe you and they will get better. But if this is the belief they have and you have worked on this belief and they later realize that, yes, there are instances where you may have pain without injury, then you have already worked on something. Special nerves in your spinal cord convey danger messages to your brain. Is it true? Is it false? Chronic pain means that an injury hasn't healed properly, which is an abnormal thing with many of our patients. For them, I have initially had an accident. It is for 3 months now. So they will think that it is because that injury has not properly healed. That is why the patient is in pain. But if they are adequately educated to know that injury can adequately heal properly, and then because of some other psychosocial components, the patient may be still in pain, not related to that previous injury, it is something worth knowing if the patient is thinking about this. This is what they believe in or not. Worse injuries always result in worse pain. Many of our therapists also, because they are practicing based on biological concepts, they believe in all this, that if you see worse pain, it is associated with worse injury. If you see less pain, it is associated with less injury. When in the actual sense, there could be worse injuries with less pain, and there could be no injury with serious pain. So this is one example of the tool that we can use to now check the level of the pain neurophysiology knowledge our patient has. And this will tell us if they have poor pain neurophysiology knowledge. We need to educate them on the pain neurophysiology so that their own negative thoughts about pain and how it is processed will be removed. And then now they will have positive thoughts related to pain, and then their pain outcome will improve because a lot of fear and misconceptions have been cleared. I think at 1:30 is better we have a lunch break. Hafiz, how long should we have the break? So that 1 hour is too long. Yes. 30 minutes? Okay. So participants, can we go for a break so that those that want to go for lunch, those that want to pray for 30 minutes so that we can come back at 2 p.m.?
Okay, sir.
Okay, sir.
Okay, so we take a break of 30 minutes. So from 1:30 now to 2, then at 2, we resume.
Okay, sir.
Okay, thank you all very much.
Thank you, sir.
Okay. Hello, participants.
Hello, sir.
Hello, sir.
Okay, welcome back to the second part of the workshop. So I have already started explaining that there are some other psychosocial component of assessment that we may have to use some subjective tools to assess and know the status of our patients. I started with pain education because many of our patients, including some therapists, they always base their own explanation of pain and injury on purely biological concept, which can be misleading. A patient that has a pain that is persisting not because of biology will always expect you to treat him based on biology. And he's expecting to even see his biology improving. You say there is degeneration here, then he wants to see the degeneration improving. There's compression here, he wants to see the compression improving. There's a laxity here, he wants to see there is no more laxity. So all those things. Of course, in some cases, there are biological reasons. And I said you should investigate them and then you should manage them based on evidence. So this education developed in the system, how pain can be managed, how is the relationship of injury and pain, what is the role of brain in pain development. They get better results in pain treatment compared to those that do not know this knowledge. But unfortunately, we also have many therapists that their concept is purely biological. So if this tool is administered to them, they will still score some questions wrongly. Meaning that if these therapists are the ones to educate their patients, they will also educate their patients wrongly. So as people say, charity begins at home. So physiotherapists have to update themselves, know the appropriate concept of pain development based on neurophysiology, so that if they are to educate patients, they will also educate patients based on the accurate neurophysiology. So we need to also get ourselves acquainted with the concept. If you do not believe in biopsychosocial concept, there is no way you can treat patient based on the concept because you also do not believe in it. Also, if you are not well versed in it, there's no way you can adequately train your patients on that because you do not know much about it. So this is one of the simplest questionnaires you can use to assess the pain neurophysiology knowledge. And from the scoring, a patient can score above average, which is the expected. A patient can score average, which is also not bad. But when patients score below average, it means his own understanding of pain is not much. And then he will always relate his pain to something wrong. And that may give him misconception and maladaptations. So that is for the neurophysiology. Is the internet having something? Am I audible? Yes. Oh, so my slides are refusing to move.
Yeah, audible, sir.
Okay, it's my slides that are not moving, so I suspect maybe is the okay. So now we have kinesiophobia. I have also explained that many patients, because of the chronic pain they have, they now tend to develop fear of movement. And we know in almost all the guidelines and the evidence-based papers, patients with chronic spinal pain, neck pain or back pain, they have to move. So if your patient is having fear of movement and you only instruct them to do the exercises and they should come back after so days, after so weeks, you shouldn't expect good outcome if you have not assessed this. Because of the fear, they may do the exercises wrongly, inadequately, or even refuse to do it. But unfortunately, when you were assessing your patient, you haven't assessed, I'm sorry, you haven't assessed them to see if they have that fear or not. So I also brought one of the tools that can be used to assess the fear of patients, which is the Tampa scale for kinesiophobia. It has 4 scores where a patient has to respond if he strongly disagree with the statement, or he disagree with the statement, or he agree, or he strongly agree with the statement. And from the scoring after it is administered, then you will know if someone has significant level of kinesiophobia, moderate level or low level of kinesiophobia. Just like the one for the education, if you know he has inadequate pain neurophysiology education, then part of the intervention you will give, you will now administer educational sessions. So the same thing also for the kinesiophobia. If the patient has significant fear of movement based on the tool that you have used, then based on the evidence, interventions that are used also to improve kinesiophobia of patients should be added to this your patient that has chronic neck pain. You can see the examples of the questions here. I am afraid that I might injure myself if I exercise. Imagine your patient strongly agree with this statement. And then it is exercise you are going to give that patient as his physiotherapy intervention. How are the two going to work for the patient? He's afraid that if he exercises, he's going to enjoy himself more, and you are giving him instruction to go and exercise. And unfortunately, you have not assessed kinesiophobia in that patient. But if you have adequately assessed, now you have seen the fear, probably you have to start managing the fear. When the fear is much better, then you now administer the exercise. Then it is a win-win. He gets better and the fear is gone. If I were to try to overcome it, my pain would increase. This is another fear. That if he wants to overcome the pain, if he tries to do whatever is instructed to do to help himself, a serious pain. But he believed that his body have something that is dangerously wrong in the body. So if this misconception is not addressed, always the patient will have that fear that his body have such things happening. My pain would probably be relieved if I were to exercise. So this is like opposite of the other question. Now you want to see if he believed that he will get relief with exercise. If it's that type of patient that believes that he will get relief with exercise, then you will easily administer exercise and the patient gets better. So if we look at this question, for example, question number 4, my pain would probably be relieved if I were to exercise. If he strongly disagree with this, it is a good score. But question 1, I am afraid that I might injure myself if I exercise. If he answer 4, it is a negative score. So that is why the questionnaire at the end, when the total scores are added, there is what is called reversed scoring. Usually some questionnaires, if they are developed, these kind of questions are inserted so that patient will not, or participants will not be choosing questions continuously, 4, 4, 4, 4, 4, or 1, 1, 1, 1, 1. Immediately he notices this kind of question, he will know that some questions are changed and twisted. So he will pay attention more to know the appropriate response to give. So this one has some components that have to do with reversed scoring. So 4 has to become 1, 3 has to become 2, 2 have to become 3, 1 have to become 4, to be in the same line with the previous questions. So my accident has put my body at risk for the rest of my life. You can see how patients can be so afraid. So now, little things that will encourage their body to be strong, to be fit, they will not do because they think they can easily fall, they can easily have accident. Pain always means I have injured my body. Just because something aggravates my pain does not mean it is dangerous. This is part of those that the scores may be reversed. I am afraid that I might injure myself accidentally. Is still a significant component of fear. Simply being careful that I do not make any unnecessary movements is the safest thing I can do to prevent my pain from worsening. So patients will be so careful that little movements, they have to think over it. Okay, this is how I should do it. If they want to cross a gutter, they have to adjust, they have to lift their leg carefully. All those things that instill so many fear in them about movement. So all these components, if you have not assessed them and you have not addressed them, then you will be addressing patients with pure physiological interventions, and patients will not be getting better. And then you will be saying physiotherapy has not been working for this, your chronic pain patients. So many of the interventions that we have in chronic pain patients are not that hands-on that a physiotherapist have to physically administer this and do this and do this. I wouldn't have this much pain if there were not something potentially dangerous going in my body. Although my condition is painful, I would be better off if I were physically active. This is a good question that will go for reverse scoring. So many questions are put in the scoring. So if you are going to use the TAMTA scale for kinesiophobia, now you have to now know how this scale is used, how it is scored, then what are the categories? From which score to which score is patient said to have significant kinesiophobia? From which score to which score is having moderate, is having low kinesiophobia? Then another one is for fear avoidance. You also can now administer this to your patient. The answers completely disagree, moving towards completely agree. We can see the first question here. My pain was caused by physical activity. Disagree or completely agree. My physical activity makes my pain worse. If they believe in this, for sure they will not be getting better when you give them physical activity and exercises to be part of their intervention. They may not do them, or they will do them, but with the hope that they will not get any better. And then these patients will not get better. Physical activity might harm my back or my neck, as the case may be in the neck pain. I should not do physical activities which might make my pain worse. Neck pain. My pain was caused by my work or by an accident at work. So completely now they will relate it to their work, and now they will be so careful. They will not be able to be working efficiently because they think it is their work that makes the pain this way. That is why those participants that are always thinking of the ergonomics in the chronic neck pain, it is a very dangerous one if you always relate it to their work. In chronic pain, in acute pain, it might be actually related, but in chronic pain, it is probably because of some fear and other things. And if you relate it to that, then it will continue to be like that. My work aggravated my pain. I have a claim for compensation for my pain. You can see how possibly, for example, the psychological aspects might influence. Probably maybe someone that is working where when you have pain, you have to be compensated. you don't need to go to work. They will give you some allowances. For example, maybe in the military or paramilitary. So because of this, then they will continue to be in pain psychologically because of the benefit they get. And if you have not assessed to this extent, then your patients will not be getting better, and it's because you have not done your own homework well. My work might harm my neck. I should not do my normal work with my present pain. They want to avoid their work now. So all these are questions related to fear avoidance. You avoid something because of the fear. So it also has the scoring, and based on the scoring, if you have used this for your patient, then you will know if the patient has significant fear avoidance or doesn't have. Those that have it, then you have to give intervention that are found to be effective in managing patients that have fear avoidance. So these are just examples of tools. There are many tools. So now I ask the question, which tool version should you use? I said, when available, always use valid culture sensitive tools. I think here we need to also have some interaction with participants. We say we should use tools that are culture sensitive. What does that mean, participants? If we are to assess the fear avoidance, if we are to assess the education, if we are to assess the kinesiophobia, if we are to assess the disability, whatever. What does that mean if we said we have to use tools that are culture sensitive?
Well, I think it means the fact that each individual is different, and maybe you have to, take their culture, their tribe, religion, and every other thing into consideration. So maybe you go to the tool that would best, go with that fact, or the best capture it into their psychosocial aspects of the pain they have.
But if I get you right, so for example, these examples, the ones I gave, will you use them like that or how?
Well, those ones are kind of more or less general. If you ask me, they are. I don't think anyone mentioned culture that I see of.
So how would you go about it?
I wouldn't know. That's why we are on this platform.
Okay, yes, who is talking? Dr. Naoro?
Good afternoon, sir.
Yes, good afternoon.
For me, I think from getting the subjective examination and looking at the biodata for this kind of patients, and from my other examination, like knowing how the patient, what kind of bed or the kind of occupation this patient does, I can be able to choose, because from the examples of the questionnaires you've given us, they are all reliable and valid. So from my subjective assessment and my objective examination, I should be able to choose one or two of these questionnaires that will best fit the goal I'm trying to achieve for these patients. Thank you.
Okay, so you can just pick them and use them right away. Okay, it's interesting. Can I get more responses about which tool or which questionnaire will be? Dr. Udochukwu?
Good afternoon, sir.
Yes, good afternoon.
So just to reiterate and to point out what Dr. Enahoro said, I agree with him.
Okay.
But I just want to point out cultural sensitivity may not basically just be tailored to because of someone's culture. It also encompasses their beliefs, their values, what they feel, of course, along with their cultural beliefs. So, I mean, along with what Dr. Enahoro said.
Yes, it is interesting. We have to know that culture has many domains in it.
Yes.
So the easiest one is the language.
Okay.
the language we use is part of our culture.
Yes, sir.
Yes, so if there is this tool in Urhobo language and you want to use a tool for Urhobo patient, then you should get a valid tool that is in Urhobo language.
Yes.
So these tools I gave example of are in English. So if we have them in the patient's language, they are the best. So that is one, language is part of it. Then literacy level is part of our culture. You may get to certain tribe, certain locality, where maybe the literacy level is very low, and the language used in a certain tool or questionnaire is too complicated and may require them to even read. So you can see that one is not culture sensitive for them. It didn't consider their sensitivity. Am I making sense?
Yes, sir.
Yes. Also, the communities, the development. So many things need to be taken into consideration to make something culture sensitive. So if, based on evidence, it is recommended that you should screen someone for kinesiophobia, for fear avoidance, for pain education, for this, then if such tools exist in a culture sensitive form for the patient's population, then they are the best to use, because they are the ones that will capture the peculiarities of the patient. Probably these tools that were initially developed, they were developed for population in the West. And maybe if you use them exactly the way they are, they may not give you the best outcome. So that is why I have to throw this question. So I have to just give an example so that when we are practicing, we shouldn't look down on tools developed that are sensitive to our patient's population. Well, unless if we don't have them, then we should go to other tools. But if we have them, we should use those tools. So I'm giving an example here. I'm sorry if I miss the language of some of our colleagues. I have to just give 3 examples of the predominant languages we speak. There is translation, cultural adaptation, and psychometric testing of the Yoruba version of fear avoidance belief questionnaire for patients with low back pain. So this is for fear avoidance belief, isn't it? And it is for Yoruba population, for low back pain. So the only thing is, if you want to use it for neck pain, is where low back pain is mentioned. You are afraid to do this because your back pain will get worse, then you replace it with neck pain. Then you use it for your patient that is Yoruba. So it's better than to use the English version of the fear avoidance belief. And when you read the two, you will see where some differences are existing based on the explanations, and in addition to using Yoruba language to express the content. And then below it, there is translation, cultural adaptation. That one is by Mbada Chidozi. I think he worked with, yes, University of Obafemi Awolowo University, Ile-Ife. Then translation, cultural adaptation, and psychometric testing of Igbo fear avoidance belief questionnaire in mixed rural and urban Nigerian population with chronic low back pain, also for low back pain patients. So you only need to change chronic low back pain to chronic neck pain. And then for Igbo speaking patients. And this will consider the peculiarities of Igbo population. So it is better to use tools that have been developed for that. This is developed by Dr. Igwe Shidobe. I gave an example of a tool I developed, development of culturally sensitive pain neuroscience education materials for Hausa-speaking patients with chronic spinal pain. Spinal pain is neck, thoracic, and low back pain patients. So pain neuroscience education materials that can be used. So if it is recommended that patients that have less neurophysiology knowledge of pain should be educated on pain neuroscience education, then you should use the tool that exists in that language. And coincidentally, then I have developed for Hausa speaking patients. So instead of you to pick the one that is for English-speaking patients, then you should use the tool that is developed for the population of your interest. So any of those tools, disability, quality of life, functions that you want to assess in this your patient with chronic neck pain, check if that tool exists in a culture-sensitive form for the population of the patient. And you check if it exists, if it is valid and reliable. If it is valid and reliable, and it is in the culture-sensitive language of the patient, then you should use it as the most preferred tool to be used. If it doesn't exist, then you can use the English version or whichever language is the original version. Probably you have to be explaining it to the patient, but you should know that in that case, there are some limitations because you cannot have it administered exactly the way it is, and the patient may not also comprehend it exactly the way it is meant to be comprehended.
Sorry,
so there
sir.
are some other,
Yes, sir. Like in a place where we are having some language barriers between the clinician and the patients, and we have to use a valid questionnaire, as you said, and we are in a kind of culture or ethnic where most of the questionnaires that are valid, so to speak, are in English.
Yes.
Will I not have this challenge of making the patient understand what I'm trying? Because there are cases where I'm going to say some things that the patient may not really understand, but will have to just answer yes, just because it just wants to please me. Will that not be a kind of me shortchanging myself? That's why I'm saying if we are talking about bringing these questionnaires into our native language, we know most of us, most of the questionnaires being developed in Nigeria, for instance, are actually in English. We have very few, very few that are being interpreted in our local language. So how are we going to have, how we will not have challenge with this, especially when it comes to our documentation and using this for research purposes? Thank you.
Okay, so thank you very much. I think two perspectives here. For clinical practice, if it doesn't exist in culture-sensitive form for the patient's population, of course, now it is a limitation, but you have to now use the one that is available in other language. If you are able to get the desired result, that is what we are looking for. If the result is not as effective as what they get in other parts of the world, we may attribute maybe the lack of sufficient result to lack of tools that will adequately assess such parameters from the patient and to assess their improvement. For example, the patient has fear avoidance, and the information in the fear avoidance in English, they are not the ones that are so compatible with the patient. But it's still better than not assessing fear avoidance completely. So it is a limitation that at the end, the fear avoidance you got is based on the English version of this questionnaire. Probably if there is a questionnaire that is based in his local language, the patient might have responded better, and you might know the best fear avoidance of that patient. But it is due to lack of it that you are using the English version. And then the second component you asked for the researchers. That is why it is always recommended for researchers that the most commonly used tools of clinicians, probably maybe I come to the clinic where you work and I check the most commonly used tools there. Are they part of the recommended tools that should be used to assess such kind of patients? If yes, then we should recommend researchers to translate them also for patients. If they are not the ones that are the best for such patients' population, it's good to educate the clinician that for chronic low back pain patient to check disability or to check quality of life, the most recommended questionnaires are this and this. The one you are using is not among the highly recommended ones. So it is also an assignment on the clinicians that any tool you are going to use based on the evidence? Are they part of the recommended tools that should be used for such patients population? If we are not using the recommended ones, we should change our practice and use the ones that are recommended. And if those recommended are in our local languages, we should use them. If they do not exist, we should use the ones available. And in research, this is one of the justification of you going into a research of translation, that a number of these patients having this condition exist where we practice. This tool is used to assess their outcome and to see how they progress. Unfortunately, the tool is only available in foreign languages where the language used and some of the examples and the narrations used are not compatible with what is obtainable in the population of the patients that are the end users. So there is need to have a translation and cross-cultural adaptation of the tool to fit the population of the patients that are at the end using the tool. I hope I answered your question, Doctor.
Yes, sir.
Okay. So after that, then I gave examples of tools here that are also commonly used for patients with neck pain. Aberdeen Spine Pain Scale. The construct that is meant for this is for pain, so it assesses pain. It is generic. When we say generic, then it is not specific to only neck pain. Maybe acute neck pain, chronic neck pain, whiplash, or whatever. Bone mouth questionnaire, it is for pain, generic. Then cervical spine outcome questionnaire. This one, it assesses the pain, function and disability, psychosocial status, healthcare utilization. So you can see it has covered many components. So a clinician that wants to assess pain, function, disability, psychosocial status, so instead of him to get a pain questionnaire separately, a disability questionnaire separately, a psychosocial status questionnaire separately, then should choose a questionnaire that have different domains so that the patient will not be burdened with responding to different questions and will even get tired of responding to the questions and may end up answering some of the questions inappropriately. When you start getting tired, after the first questionnaire, the second one, you'll just be choosing tools, responses arbitrarily. So you choose also a questionnaire that may be the best for the patient that the patient can respond to within an acceptable duration of time. Then Copenhagen Neck Functional Disability Scale. It is for function and disability. Then current perceived health profile. It is for pain, functional disability, psychosocial status. Then global assessment of neck pain. It is for function and disability, but this one you can see it is specific, so to the neck pain. So if questionnaires that are specific exist, they are more preferred than generic, because specific, they only consider that condition while developing the questionnaires, while the generic, other conditions were also considered so that it can be used for different conditions. So there are neck disability index. Many languages have the translated neck disability index in Nigeria. So if you want to use it, you can look up to the translated versions if they exist in the language of the patient you want to use. Neck pain and disability index. Okay, I can see two neck pain disability index. The neck NDI, then neck pain and disability index, NPDS. Both are specific for neck pain. Northwick Park Neck Pain Questionnaire for function and disability, and the rest. So while practicing, we can look up and see if we have the ones. Sometimes the questionnaires, maybe you prefer to use this questionnaire, but there is the other questionnaire that is available maybe in the cultural aspect, translated and culturally adapted version for the patient's population. Maybe because of that advantage, now you have to use that questionnaire instead of the most preferred one that doesn't exist in the patient's language. So for clinical reasoning now, when should these examinations and tests and assessments be carried out. It is from the history of the patients and all the assessments that you will now determine to see if you are suspecting a structure that is at fault or you think there is no structure at fault. If you think there is no structure at fault, no need for you to carry out some examinations that are meant to diagnose faults. But you can carry out examinations to know, for example, range of motion, to know muscle strength, because pain can make joint range of motion to be limited. Pain can make muscles to be inactive and to be weak for that. So does it always make sense to look for pathology? Of course, from our discussion today, it doesn't make sense. There are many chronic neck pain cases of the predominant part of them do not have a pathology that you can directly say this is the condition that makes the patient to have chronic neck pain. What of radiographs, lab investigations, and diagnosis? We shouldn't insist that we must diagnose this patient because we have our own acceptable diagnosis that we can say this patient has chronic non-specific. If you have not been able to relate the development of the chronic pain in that patient to any condition, then you can just accept that this is a non-specific neck pain that is chronic, instead of you trying to say that there must be acceptable biological reason to say this is the reason why the patient is having the pain. The radiographs we have mentioned, if there are indications, you can go for them, but you have to be careful with interpreting their results, correlate their results with their examinations, with the complaint of the patients and everything. Lab investigations, if there is also indication for you to now check some of the interventions you want to give, maybe individuals that are weak because of social condition need to be investigated, then you can check for them. Tuberculosis of the spine, someone with sickle cell disease, and whatever, so that some of the examinations or some of the investigation interventions that will require rigorous activities, we will be careful with how to administer them. So pain without pathology, it is obvious. So we have to relate this to how we assess our patients. Any emphasis on the trunk and lower limbs? So for patients with neck pain, this may be a question also for the participant. Do we have to give emphasis also to the trunk and the lower limbs? Participants? I'm expecting some responses because we haven't talked about the trunk and the lower limbs.
Afternoon, sir. For me,
yes.
I think if it will have to involve, because what we are dealing with now is the cervical vertebrae. So if it will have to deal with the lower trunk, I think it will be better the patient should be referred for radiological investigation to rule out any red flags. Because for me, I think for the upper for the cervical region, it's supposed to affect more of the upper limb. But if it's beginning to radiate and affect the lower limb, I think it's better we call for further examination.
Oh, any more response? Thank you, Dr. Nahoro. So I think, yes, I said, usually you examine and you even request for maybe radiological imaging if maybe condition is progressing. A patient that have a symptom and over the time, the symptoms have been progressing maybe from the upper limbs now, symptoms are going to the lower limbs, some weakness, presentations, or maybe initially there were no difficulty in breathing and related symptoms of the chest, and now there are such symptoms. So when there are such signs of progression, then you may request for more investigations, and you may even refer the patient for further investigations by other healthcare professionals. But under normal circumstances, when we assess the patient based on what is linked to the neck region. But for the lower limbs, if you want to assess for intervention, because, for example, the physical activities, the exercises, and what have you that will be recommended as supported by the evidence, they will require cycling, they will require exercise, jogging, they will require this. So you need to make sure that the patient is examined, that the lower limbs are fit for that. Otherwise, you go for alternative interventions or exercises that will not require that, because probably maybe there are elements that are not related to the neck pain, but they affect the lower limbs, and they will affect the interventions you will give to the lower limbs. We have to understand the concept that, for example, exercise improves neck pain. The exercise mustn't be exercise in the neck region. Cycling that is predominantly by the muscles of the lower limbs will also improve pain in the neck region, because at the end, all the physiological benefits and the components of the descending tract from the brain, where dopamines, the endorphins are released, is from the brain, and it responds to exercise, irrespective of where the exercise is performed. And this needs to be educated to the patients. Patient that has, for example, neck pain, and you give exercise that is away from the neck, and the patient is thinking, this exercise is not meant for my neck. If you have not done your work well by explaining how all this neurophysiology works, how pain is relieved, then the patient will think, I don't need to even do it, because this doctor is insisting I should do this, and my problem is not in the lower limbs. So all these things need to be taken into consideration. So now, the aims, what do we aim to treat now in the patients? Obviously, it is chronic neck pain, so we have to aim a relief in the pain. If it is possible, we have to alleviate the pain. So the patient should not have pain at all. But if we cannot, then we have to relieve the pain. But that is not the only thing we should target. If there are maladaptations and wrong beliefs, we have to correct this maladaptation and the beliefs that are wrong. Otherwise, this maladaptation and wrong belief will always come and worsen the pain of the patient. If the patient is having associated fear avoidance, we have to work on his fear avoidance to make sure that the patient has improved fear management and is able to do things without getting scared, getting afraid. Education. Is the patient adequately educated? And not just adequately educated in the right concept. Not, for example, patient getting educated based on the biological concept that injury, pain, no injury, no pain. All things associated with the development of pain or no pain should be part of it. Part of the things that in my education tool that I developed, some questions, I start with simple questions. And probably, maybe some therapists may also respond wrongly. We often ask some of the patients, when we ask them, okay, is pain important in our life? They respond, pain is not important. And when I go ahead and ask more questions, do you want to live a life free of pain at all? They will say, this will be the happiest life they can live, but they can't feel any pain at all. But in the tool I developed, when I now give them examples of, for example, a child that is with his father, they have gone to the farm, and maybe the child was bitten by a snake. And then the child, because of the pain he got from the snake, he shouted to the father, and the father has to respond to see it is a snake that has bitten the child, will now rush the child to the hospital. and then may receive antivenom, then the life of the child is saved. Then I will now ask, what of if that child couldn't feel any pain? So he couldn't even know that snake has even come close to his feet, has even bitten him. What will happen? In few minutes, the child will fall down, the child will die, and the child is gone. Then my patient will start, oh, then in that case, it is the pain that draw the attention of the child that something happened to him, even the father, even this, and then medical attention was taken. So this is the same way pain serves a role in our body. So if you haven't done all this to your patient, then they will think completely pain has no role in their body. Disability, if there are things that they have not been able to do, even if the pain is reduced, you are using maybe an outcome measure for the pain, and the pain has significantly reduced. You are happy, you are telling the patient, see, when we started, your patient is at this level. And presently, your pain has come down to this level. So we have achieved a lot. But for that patient, there is something very vital in his life that he needs to be doing. And he's still unable to do it. So the patient has not progressed. And that would be possible if you have not assessed his disability. But if you have assessed his disability, then you will now know from the disability aspect, he is now unable to do this, unable to do this, then you can work on that. The same thing with functions. They'll sleep. I mentioned that many of our colleagues hardly assess sleep of their patient and know if their chronic pain, for example, the neck pain, greatly affects their sleep. And we hardly also incorporate outcome intervention to improve quality of their sleep, then overall quality of life. So it is based on the assessment that you had with the patient, then you will know among the available aims, what are you going to target. If the patient has normal adaptation, no wrong beliefs, you don't need to target this as your aim. If the patient has no fear avoidance, no need to target this. Adequately educated, no need to target this. But if they have, then you have to make sure that you target those things. So the treatment that you will now choose when you have given your own aim, it has to be evidence-based. We always talk about this evidence-based, but I need to still get a response from our colleagues. How do we practice based on evidence-based? So with the example of the neck now, if we want to practice based on the evidence, how is it? Participants, are we sleeping?
We are thinking. Yeah, I am thinking.
Yes.
Yes, sir. Concerning evidence-based practice. Yes, sir.
Yes. Yes.
Concerning evidence-based practice, research has shown that, let's say, for example, a patient has come down with compression syndrome, okay, at the neck.
Yes.
Research has shown that traction, maltraction, as the case may be helpful for this kind of situation. So when patient presents with this, and after your assessment, and this is part of what you want to do for the patient, then you go ahead and carry it out properly for the patient. You know, this is evidence-based practice.
Okay, thank you. I get your perspective, Dr. Ifeanyi Chukwu. Another participant?
Hello, sir. Good evening, sir.
Yes, good evening.
Sir, like in the case of the cervical spondylosis, so research showed that a patient can receive a kind of manipulative therapy, which is either thrust or non-thrust. So in the situation
Okay.
whereby a patient is presenting with that condition, yes, sir.
Okay. Yes. Who else, please? I want to learn more.
Yes, in the case of spinal spondylosis, we can, cervical spondylosis, we can also use Maitland grade 1 and 2 for pain relief.
Okay, Dr. Nayaya. Okay. Who else, please? I'm learning.
And also, sir, in the case of neck stiffness, research show that range of motion exercise can improve.
Okay.
Can help in the neck pain.
Okay.
And also massage that include the muscles around the neck can also contribute to pain of the relief of the pain around the neck.
Okay. Please, I want more input. I'm also learning.
Good afternoon, sir.
Yes, good afternoon.
Yes, like for my talking about evidence based, like from work that I've done on it, most of it evidence based now are now majorly on algorithm, which means each particular condition I have diagnosed will be based on there is a treatment plan I have to follow. Take for instance, like the NICE guideline forbids me using manipulation or cervical traction for my patients. They prefer more of exercises and education. While for other than the World Health Standard, for instance, they still permit me to use manipulation and cervical traction for some sets of patients. So it depends on what I feel is best for that patient at that particular moment. So that's why I say evidence-based is always trying to be dynamic in its way of management.
Okay, thank you very much. Can I get more responses before I respond? Yes, Sharifat.
Yes, in the case of evidence-based practice, it has also been confirmed that postural education also works very well, especially when it has to do with postural education.
Postural education.
Yes.
Okay.
Has been shown to be very, very effective in the course of treatment. Also, as part of the treatment, this thing, especially for cervical conditions.
Okay, okay. Do I get some more inputs before I comment?
Yeah. Well done, sir. For me, I think I'm looking at it from the screen that is evidence-based practice. It's a mixture of the individual.
Why are you looking at my screen?
It's right. Also, I am trying to look at it and it actually makes sense because there are some situations whereby you will see evidence and the evidence is in some cases you might have to make clinical decision based on your clinical expertise that this is what I've done so far and this is what has helped this category of patients in your own experience. So the findings, it might not be enough to generalize, but you know that it's just the right thing to do that could, help with this patient. And sometimes you can use evidence. Evidence-based practice is like to some category of patients, you understand? So mostly it will work, but there are some cases that they'll be like, oh, for this kind of scenario, use cold therapy. And the patient will be like, cold therapy does not work for them, that hot therapy is what works for them. So I think it's a mix of what you just put here exactly. Patient sometimes know what to expect. That's like you having patient-centered care. They have their own expectation and sometimes they have a clear mind as to how their body is. So asking what their expectation is about their treatment, you having your own clinical expertise, and why be aware of what is out there in terms of literature. I think, yeah, and also, you know, keeping up to date with that literature. So I think it's makes us be able to carry out the best practice, I would say.
Okay, thank you very much. So I think I can respond. I got interesting comments, and it's good to also get the views of our participants so that we will know how best we look for the evidence and how to use the evidence. A few of the colleagues, Dr. Ifeanyi Chukwu, Dr. Suleiman, Dr. Nayaya, you mentioned based on research, or research papers, research articles. So when we come to issue of the evidence-based practice, we have to be careful with which type of research. All papers that are published based on data, they can be called research papers. So we have to know which type of research is it. Is it even a research that is meant to find evidence of effectiveness of intervention? If yes, how strong is it? So that is why in the concept of evidence-based practice, then one component is to get the best external evidence, which is from the research. And in research, we have different level of research articles that can be used to get evidence. If you can get systematic reviews and meta-analysis that are published on the population of your interest, for example, chronic neck pain now, then that is the highest level of evidence that you can use. Systematic reviews and meta-analysis in the population of your interest. If that is not available, then randomized clinical trials, they should be used. But the difference is systematic reviews and meta-analysis, they bring in usually different randomized clinical trials together to summarize their results. So you don't have the headache of reading Article 1, Article 2, Article 3, Article 4, Article 5, Article 6. They have brought them together, see their results, and bring out the summary. But if it doesn't exist, then you have to start reading these randomized clinical trials individually, getting their results, their limitations, and then comparing them with other results from similar randomized clinical trials, and then also assessing the quality of the randomized clinical trial. An RCT can be used if it is adequately conducted and it has low risk of bias. So you may see a study that says cold therapy or heat therapy is effective in the management of chronic neck pain. But if you will subject it to quality tests using tools of assessment of quality, then that study will be adjudged as poorly designed. Then you cannot use the finding of the study. So many of our clinicians that do not bother to read more about how quality of studies are ascertained, immediately they see a paper well presented, the journal is very attractive, it is online, and the finding is this is beneficial in the treatment of chronic neck pain. They will go ahead and use it. But in evidence-based practice, we will not trust the finding of that article till when we now check how good is it designed. Is it having minimum risk of bias or it has high risk of bias? If it has high risk of bias, the findings cannot be used. If it has minimal risk of bias, then are there other studies similarly conducted that also support this? Or there are other studies similarly conducted, but they have opposite of this result?
So that is why if systematic review is there, it takes care of this. It has to check the quality of the individual RCTs and the results. And at the end, it will tell you maybe there is a conflicting evidence because maybe 3 out of 6 studies they are saying is beneficial, while the remaining 3 are saying is not beneficial. So there is conflict. So based on that, the systematic review will tell you don't use that intervention. They will only give recommendation that further research should be conducted because there is conflict in the findings. This are saying is beneficial, this are saying is not beneficial. So we have to know if we say research paper, which type of research paper. If it is systematic review or meta-analysis that is telling us this, we may just go ahead and use it. But still, I will talk about other components when we are choosing the study. Then another thing, Dr. Ifeanyi Chukwu, he mentioned, so if a research paper mentions something is beneficial, then we have to check on which outcome. Now, chronic neck pain patients, maybe you have finished assessing your patient has pain. Your patient has fear avoidance. Your patient has kinesiophobia. And that research paper, even if it is systematic review or meta-analysis, it now says, for example, exercise is beneficial in improving pain intensity. So you can now use exercise, but your aim is to improve pain. Now go and look for evidence where also which intervention can be given to improve the fear avoidance, which intervention can be given to improve the kinesiophobia. So that is why I say in the previous slide, I say, what are the aims? If your aim is to improve pain, then go and look for studies on pain intensity. What is the best way to manage pain intensity in chronic neck pain patients? Then you use that intervention. But if there are other components that you want to improve in your patient, you also need to go and look what is the best evidence to manage those outcomes. Then that way, you will now manage your patient as a whole. Otherwise, you may adequately manage one outcome and leave other pressing outcome behind. So in the concept of evidence-based practice, so you have to get that evidence, the external evidence. Then you have to also consider your own expertise. If they mention this and this and this should be used in managing the patient. For example, they said the patient should be educated based on pain neurophysiology concept. Do you have the expertise in pain neurophysiology concept? If you know that you are a staunch believer on biomedical concept of pain, then you cannot administer that pain neuroscience education, for example, to the patient. So you have to consider your own clinical expertise. Then you have to consider patients' values and expectations. What do the patients expect? What are the values? What are their peculiarities? A patient that may find it difficult to even get a release from his place of work to come for intervention, even if, for example, we have supervised exercises and we have unsupervised exercise. So in the evidence says supervised exercises administered 4 or 5 times a week for 6 weeks. They improve pain intensity, they improve quality of life, they improve fear avoidance, they improve this. And you want to use it for the patient because that is the best evidence. You have to now consider his values. It will be difficult to get a release once in a week to come for intervention. And this evidence is saying supervised exercise. So in that case, you cannot use that best external evidence. Probably you have to move to another evidence that may accommodate the patient values and expectations. So these are the explanations that, so we have to consider these things. When we consider them, then we will now, where we have the intersection of the best evidence, our expertise, patient values and expectations. So that intersection is where we practice based on evidence. So this is what I mentioned in the hierarchy. So if we have systematic reviews and meta-analysis, then it is better to do it this way. If we don't have then randomized control trials, but in them, there are maybe a number of them published. So reading one cannot make you to have a judgment. You have to read the existing ones in the same field. So the population of concern is very relevant here. Dr. Nayayash, you mentioned cervical spondylosis. I am not sure in physiotherapy, but let me ask our colleagues. Is it a physiotherapy diagnosis to say the patient has cervical spondylosis? Colleagues?
That is a medical diagnosis.
That's a medical diagnosis.
In physiotherapy?
I think physiotherapy. Yeah, physiotherapy deal more with physical diagnosis. So that's clear. Cervical spondylosis is a medical diagnosis.
Can there be a cervical spondylosis without pain?
Yes.
That is why it is not our diagnosis. Because cervical spondylosis is degenerative disorder of the cervical region. If you look at the X-ray, you see narrowing of the joint space, you see marginal osteophytes, you see this, you see this. They say the patient has cervical spondylosis. But if the patient doesn't have pain, what will you do? No limitation of movement, no discomfort.
Nothing. The patient is okay. At least the body is not telling him or her that he's in danger. So it is until something is wrong. So pain is like a signal. So it tells you something is wrong.
So that is why we said we should always try to avoid biology unless if there is a reason. Because that patient that you told has cervical spondylosis, even if he has no pain, the patient will go and continue to have fear. Probably in the past, he freely moves the neck, he enjoys his life. Now he'll be so careful, afraid of moving because doctor says, I have spondylosis. Also interesting that review method. Then in the hierarchy, you also place them So when you now check in the level of evidence, usually there are different levels that exist. The highest level can be using different nomenclatures based on the authors. Maybe they will say strong evidence, or they will say high evidence, or they will say excellent evidence. So any guideline you are looking at or systematic review, if they mention their level of evidence, go through it and see, based on their own categorization, which evidence is the highest possible, which evidence is the lowest possible. So if high is their maximum, fine. If strong is their maximum, fine. Excellent is their maximum, fine. What is next to it? Is it moderate? Is it medium? Is it intermediate? Then you have to know in their own categorization what they want to say. In clinical practice, you should always target the maximum evidence or the immediate level of evidence. That is to say, there is strong evidence that this is beneficial, then you should use it. There is moderate evidence that this is beneficial, you should use it. There is strong evidence that this is not beneficial, you should not use it. Because it is two ways. Systematic reviews may reveal that there is strong evidence that infrared radiation is not beneficial in the management of, for example, chronic neck pain patients. So there is strong evidence that infrared radiation is not beneficial. So you should use that level of evidence. So don't use infrared radiation. There is strong evidence that exercises in aerobic form are beneficial in the management of neck pain patients. Then you should use it for neck pain patients. So the same thing with moderate. So strong and moderate are the ones that are always recommended. So where you want to practice based on evidence, maybe there is strong level of evidence, but it's not compatible with patients' peculiarities, expectations. Then maybe there is a moderate level of evidence for another intervention that intervention is compatible with the patient. Then in that case, if you want to practice based on evidence, then you have to use the moderate level because it is also acceptable in practice and it is the one that will be compatible with the patient. Or the one that is having strong level of evidence, you have no expertise in administering it. But the one that has moderate level of evidence, you have expertise in administering it. Then you go for that. Then by that, you are practicing based on evidence. Weak and low evidence usually are upcoming evidence. Probably maybe there is insufficient study. So maybe the studies in the field, they are few. So they are not enough to make judgments. Or maybe the strength of the study that make the recommendation is not the best design. So they are only recommended if maybe it is a new area and probably maybe there is need to carry out research in the area to come up with what is effective and what is not effective. And so usually this is recommended in research where ethical approval will be sought. And then the ethics committee will now look at what you want to do and you will do no harm to the patients. Then they will recommend that you can go ahead and do it so that we can see at the end if more studies are conducted, this intervention is beneficial to the patients or not. Poor evidence should outrightly not be used. There is poor evidence that this is beneficial, don't use it. There is poor evidence that this is not beneficial. Completely poor evidence is no-go area. Then conflicting evidence. Is beneficial, is not beneficial. Another study is saying beneficial, another study is saying not beneficial. So this is an area where you have to wait for researchers to come up with concrete results, whether if it is beneficial or not beneficial. So if it is beneficial or, yes, if it is beneficial to the patient, then on which outcome? Is it on pain, intensity? Is it on disability? Is it on quality of life? Is it on range of motion? Is it on fear avoidance? Is it on kinesiophobia? Is it whatever outcome it is beneficial on? Then it is that outcome that you will now look, is your patient having issue with that outcome? If yes, then you will now use the finding of that evidence to treat your patient. But you may find some evidence that will say something is beneficial on so-so outcome, but your patient has no problem with that outcome. So that intervention is not for your patient. Some individuals may come and say, you are managing neck pain patients and you are not giving them this, you are not giving them this. This is what is beneficial to neck pain patients. Yes, I agree that is beneficial to neck pain patients in improving this and this, but this my patient is not having problem with those outcomes. So I'm using interventions that are peculiar to the complaints of this patient after my assessment. So if that also is addressed, then you have to look at how recent is the evidence. If the evidence is very old, you are not sure if maybe upcoming studies, the studies that were published recently have not changed the direction of the interventions or the evidence. Maybe as of then, because of the studies that were published then, intervention A is the best. But as more studies have been conducted recently, then the evidence had been upgraded and updated. So intervention is now the best, not the one that you know in the past. So you have to check how recent is the evidence. And also how extensive is the evidence. Maybe the evidence that was developed is based on just searching just one literature database, while now there are other evidence based on multiple databases. So evidence generated from searching multiple databases are always more reliable than evidence generated from just searching one database, because some studies may be published in one database but not in the other database. So the more the number of the database used in generating the evidence, the better. Then the population, you have to be very careful with the population. If they say this is for chronic non-specific neck pain, so after the assessment of your patient, have you been able to diagnose that your patient is having chronic non-specific? If it is a disc prolapse case, then don't use the evidence for chronic non-specific neck pain for disc prolapse patient. Go and look for the evidence for disc prolapse patient. So you have to also pay attention to the population of the patient. So I'm giving now some examples here. The effectiveness of conservative treatment for patients with cervical radiculopathy. So if we look at this conservative treatment, so already they have told you that they have limited the choice of their interventions to only conservative treatment. So non-conservative are not part of this recommendation. So you want to get conservative intervention for your patient, then you can look at this, for example. And it is for cervical radiculopathy. So any of your patients that you examine that doesn't have radiculopathy is not part of what you should use this evidence for. So you should limit it to your patients that have cervical radiculopathy, and it is conservative treatment you are interested in. So if we look at the result, so they said there is low level of evidence that a collar is no more effective than physiotherapy at short-term follow-up. So I think also, who asked me about in the expectations, I should come back here. Yes, in the expectations, there was someone that asked orthosis, which ones are recommended in patients with chronic neck pain. So in this, you can see it is for patients with cervical radiculopathy. So in patients with cervical radiculopathy, they are now telling us that there is low-level evidence that a collar is no more effective than physiotherapy at short-term follow-up, and very low-level evidence that a collar is no more effective than traction. So for physiotherapy and for traction, collar is no more effective than any of the two. So you can't prefer collar than physiotherapy. You can't prefer collar than traction. So in this, we can say we shouldn't use collar. There is low-level evidence that traction is no more effective than placebo traction, and very low-level evidence that intermittent traction is no more effective than continuous traction. So based on this also, traction and placebo traction, where probably you put all the items, you instruct the patient, stay calm, and put in the distraction machine and putting it on. But in the actual sense, you didn't even plug it on. And then you compare with the patients that actually receive the traction. So either way, none is better than the other. So based on this, you can see all the results are based on low-level evidence. And we said we should look for studies that have high-level evidence or moderate-level evidence. So at the end, probably the findings from this systematic review may not be beneficial to your patient. Then evidence for the management of cervical radiculopathy. Then I brought another one here. And from the results of this, they are telling us here that there is very low certainty evidence supporting the use of acupuncture, prednisolone. So you can see this is not just for conservative management. So even even medications, prednisolone, cervical manipulation, and low-level laser therapy for pain and disability. So there is low-level certainty evidence, which we said it can only be used with care because moderate and high level evidence, they are the most preferred. But even for this, so they are for use of acupuncture, cervical manipulation, and laser. But for which outcomes? For pain and disability. So if your patient has other issues related with fear, related with kinesiophobia, education, then these ones are not going to address those other outcomes. They are only for pain and disability. And then this now say in the immediate to short term, and thoracic manipulation and low-level laser therapy for improvements in cervical range of motion in the immediate term. So low-level laser therapy and manipulation in the immediate term for range of motion, not for pain, not for disability, but just for range of motion. But if your patient has no concern with range of motion, then this is not a recommendation for your patient. So now I move on to a clinical guideline, but I read through the guideline. The guideline followed a systematic review procedure. So based on that, since it follows systematic review procedure, then you can now use it for your patient. But we have to know that this also, the year of publication is 2017. It probably maybe there are updated guidelines or not. But we can now come and see neck pain with mobility deficits. So is your neck pain patient having any mobility deficits? Yes. Look at this. No, this is not for you. So if the patient is having mobility deficits, so for those with chronic presentation, which is chronic neck pain that we are handling now here. So for patient with chronic neck pain with mobility deficits, clinicians should provide a multimodal approach of the following: thoracic manipulation and cervical manipulation or mobilization, mixed exercise for cervical scapulothoracic regions, neuromuscular exercises, stretching, strengthening, endurance training, aerobic conditioning, and cognitive effective elements, dry needling, laser or intermittent mechanical manual traction. So all this, if it is a chronic neck pain and with mobility deficits. But by the time you make all the examination in the neck and there are no mobility deficits, this is not for your patient. Then for chronic patients with movement coordination impairments, so there is movement coordination impairment in the patient, then patients can provide, clinicians may provide patient education and advice focusing on assurance, encouragement, prognosis, and pain management. Mobilization combined with an individualized progressive submaximal exercise program, including cervicothoracic strengthening, endurance, flexibility, and coordination, using principles of cognitive behavioral therapy. TENS. And then if your patient is presenting with chronic pain with headache, chronic neck pain, but with headache, clinicians should provide cervical or cervicothoracic manipulation and mobilization combined with shoulder girdle and neck stretching, strengthening, and endurance exercise. Then for patients with chronic neck pain with radiating pain, then clinicians should provide mechanical intermittent cervical traction combined with other interventions such as stretching and strengthening exercise plus cervical thoracic manipulation. Clinicians should provide education and counseling to encourage participation in occupational and exercise activities. We have to note that these recommendations and clinical practice guidelines are based on the scientific literature published prior to 2016. So a clinician can check if maybe this has been updated. There are more recent evidence-based systematic reviews or guidelines. But from all of them, we can see exercise is like a common factor. So any patient that has fear of exercising, fear of being active, we have to adequately address that because exercise is always recommended in chronic neck pain patients' management. Then we also have evidence for neck pain treatment, a systematic review of guidelines. This is across Europe. And from the results here, you can see they have 11 guidelines for back. We are not interested in them. We have 5 guidelines for neck and 1 for both neck and back. So from 8 for neck pain, there were consistent weak or moderate strength recommendations. I said if it is moderate, we can use the recommendations. It is weak that we have to use with care. So weak or moderate strength recommendations for reassurance, advice, and education, manual therapy, referral for exercise therapy program, oral analgesics, and topical medications. I have to talk here about manual therapy. If there are recommendations with other interventions plus manual therapy as part of them, after your assessment and your discussion with the patient, you have to adequately discuss with the patient and educate the patient. If you are given manual therapy, what is your aim of giving the manual therapy? If you have told the patient that the patient has some biology issues that you want to address with the manual therapy, you have to be sure that there are those biological issues. Because if they do not exist, after sessions of manual therapy, he will still ask you, okay, back in place, because initially he's thinking the neck is not in place. So all those things need to be taken care of if you are going to use manual therapy. So many of the proponents of biopsychosocial components, if there is no actual diagnosis for biological issues, then they don't give manual therapy, because manual therapy, it is the biology that you are trying to address. So you have to be careful so that you don't contradict yourself in managing the patients. So there are notable recommendation differences between the neck and the back pain, which we are not discussing here. Then neck pain clinical practice guidelines, a systematic review of the quality and quantity of complementary and alternative medicine recommendations. Like you can see, this is a very recent one published in 2022. So I have used it also in the acute neck pain presentation. And in the guideline, you can see exercise is highly recommended, where the green recommendation for therapies use, the red recommended against the therapies use, while the yellow recommendation unclear, uncertainty, or conflicted. So acupuncture, a few guidelines are recommending it. Exercise therapy, all the guidelines are recommending except one where it is not available as part of what they reviewed. Manual therapy, similar issue with exercise, but I said we have to be careful that if we are giving manual therapy, then we have also attributed some biological issues, maybe limitations in the range of motion. So if you have not diagnosed any problem, but you have still informed the patient, this is your neck, chronic non-specific neck pain, but with mobility deficit. So there are limitations of the movement. So when we move the joint, we want to improve the range in the motion. Massage, also, if biologically, maybe you have seen restriction in the movement, which is another component of manual management. Then manipulation and mobilization, similar with the manual therapy. For traction, we can see it is more of conflicting. Somewhere it is recommended, somewhere it is not recommended, somewhere it is neutral. Then ultrasound, recommended by a few. Yoga, recommended by a few. Another guideline published in 2020, it gives us weak or moderate recommendation, reassurance, advice, and education. It's weak. Manual therapy plus other treatments, it is moderate. Exercise therapy alone or plus other program is moderate. So manual therapy has to be combined with other treatment, but exercise can stand as a lone treatment, and it has moderate level of evidence. While there are weak evidences, which we said you have to use them based with care. So oral analgesic and topical medications, plus psychological therapies for specific subgroups. So this is where we said in chronic neck pain patients, you have to check if those psychological issues are existing. If they exist, then the other subgroups that you recommend the psychological therapies. Are there mood issues, persistent pain issues, psychological risks? Then multimodal treatment for specific subgroups also is recommended with weak evidence. Thermotherapy traction, even in the previous guideline, traction is inconclusive. Cervical autosis. So among our colleagues, someone raised concern regarding the cervical autosis. Is inconclusive. So some are recommending, some are not recommending. So it's not something that you should use based on evidence. But I have mentioned in the acute management of neck pain, not the chronic, the recommendation is a little different if you are using it for protection. But protection that have lasted for more than 3 months is not needed. So this is a guideline for low and middle income communities. So where maybe some of the resources are not available, so they make a general guideline for them, where clinicians should provide education. And we have made emphasis that the education should be based on biopsychosocial concept, not emphasizing just biology for the patient. Reassurance, advice to patients to remain active. So activity is always part of what neck pain patients have to do. Provide information about self-care options. So we are not after the acute neck pain, we are after the chronic neck pain. So we skip this. So what are the other factors that will influence your clinical decisions? In an ideal setting, you have to work based on the recommendations. But we know good practice is responsive to a range of contextual factors. Human resources, where you practice, maybe you are the only physiotherapist, or 2 of you, or 3 of you, and the number of patients you see, they are huge. So it is now your ability to make clinical decisions that should solve the problem. Are you going to manage only a few patients based on the evidence, while others do not receive the treatment? Are you going to give spacing that these patients have to come these days while these patients have to come these days? You have to make some patients to wait till after maybe this group of patients have received what is the best based on evidence. So sit down, make clinical decisions that's acceptable by your place of work, and that will be to the betterment of your patients. It will not make sense that because of workload, you are seeing maybe 30 patients in a month, and none of the 30 patients received evidence-based intervention. And your all reason is there is lack of human resource. It is better that among them there is certain clinical decision you made where it is easier for some to receive intervention based on the evidence than completely none of your patients received the evidence-based intervention because of the workload. Skills of the healthcare professional. If some of the interventions mentioned, for example, some of the manual therapy techniques, some of the education sessions, you don't have the skills, then you cannot administer those interventions. Then you have to limit yourself to those that you have the skill on. Availability of the necessary items for effective intervention. If there are tools needed for the exercises, for the manual therapy, for the education, if those tools are not available, then for sure, then practicing based on the evidence will be affected. Workload is together with the human resource, then the culture and the religion, the acceptance of the patients. How much of that intervention do they accept? How much of it based on the culture, based on the religion, they will not. That is why in the concept of the evidence-based practice, we said we have to make sure that patient is part of the intervention. The era of you attending to the patient comes, you ask all the questions, you make all the examinations, you now say, okay, you'll be coming here every Tuesday and Thursday, we will do this, we will do this, we will do this. You are the alpha and omega. You do not seek the opinion of the patient. It's not a practice based on evidence. We instruct the patient, Hajia, madam, enter this cubicle, I'm coming in. You are the alpha and omega, you just decide what to give the patient. Okay, do this, do this, do this, repeat it, repeat it, repeat it. No, you have to sit with the patient based on the evidence. Okay, this your condition, I'm able to see that you have this, you have this, you have this. The best way to manage this is to do this, to do this. Can we be able to do this together? Yes. I don't think so, because this can limit me from this, or because of my nature of work, or because of this. Okay, so if not that, what of this and this and this? They are also beneficial. It's just that they are not as beneficial as what I mentioned earlier. So sit with the patient, discuss, and then arrive at what is acceptable by both you and the patient. So some examples of practical guidelines. I am given an example from a study of my colleague. It is published in 2024, so it is very recent. A paradigm shift from a tissue and disease-based pain management approach towards multimodal lifestyle interventions for persistent musculoskeletal pain, not just neck pain, but musculoskeletal pain. And neck pain is part of musculoskeletal pain. So they got chronic spinal pain patients, neck pain patients, and low back pain patients that have insomnia. And we hardly also use the tool of insomnia assessment in our patients. So when we want to manage our patients as a whole, we ask the questions, are there disturbance of sleep? I have mentioned this earlier. If they mention that, then get also a tool that is used to assess sleep quality, to see their level of sleep quality. If it is significantly tempered, then you should add sleep quality interventions. So in this, they have two groups. One group received pain education, sleep training, cognition-targeted exercise therapy, while the other group received pain education and cognition-targeted exercise therapy. At 1 year follow-up, 40% reduction of pain and 37% reduction, improvement in physical functioning for those that receive pain education plus sleep training plus cognition-targeted exercise therapy. While for those that do not receive the sleep training, at 1 year follow-up, their pain reduction is 23%, while functioning improved by 18%. So almost the reduction in pain doubled for those that have also received sleep management intervention. So you can see the outcome of given intervention of sleep can also affect the pain, not only sleep quality, because as sleep quality improves, then the pain also improves. And then for chronic whiplash associated disorders, pain neuroscience education plus stress management plus cognitive targeted exercise therapy. And then another group, pain education plus exercise therapy, where stress management was not given. At 1 year follow-up, clinically important reduction in neck pain-related disability, 23% pain-free, reduction in anxiety, large group effect size, and reduction in sensitivity symptoms, large effect size. And there is saving of $854 compared to the other group in terms of the expenses, because stress management is now added. While we hardly consider the sleep of our patient in chronic neck pain patients, and we also hardly consider stress management in our chronic neck pain patients. So I have to now discuss some algorithms to guide us on how to choose intervention to give our patients, but I will still implore us to have maybe just 15 minutes break Hafiz, participants, does it make sense? Participants, can we have 15 minutes break?
Yes, sir. Do make sense, sir.
Okay, so we
have,
come
sir.
back. We come back by 4 p.m.
All right, sir.
Okay. Hello, participants. Hello, can we continue? Or we have to give some few more minutes?
We can continue, sir.
Okay. So I'm now also going to discuss some practical applications of what is recommended for the management of chronic neck pain patients. So in the guidelines, we can see some common things. Education is common in most of the guidelines, that chronic neck pain patients need to be educated. And the concept that need to be educated is like pain science education. So they need to be adequately trained on what is about pain and what they need to understand relating to it. And then exercise therapy, graded activity and exposure is part of what is recommended. So what are the practical things you need to integrate while handling your patients and educating them on that? You need to assess the illness perception. What do they perceive related to their pain? From injury, they think they are not going to recover, they think something very serious is in their body. All those perceptions, you need to assess and document them so that you will target to now change their misconception. Then screen indications. Make all the screenings. After getting the perceptions, you now screen them based on their perceptions and what you get. Are they indicated for pain education or not? If they don't have wrong perceptions, they don't have all those things, then they are not indicated. Then you have to then shared decision making. You have to discuss, because in evidence-based practice, you and the patient have to interact. So you have to share the decision. Okay, there are these things that ideally, based on the science of how pain is developed in the body and how patients should get better, they need to be changed. But together, we can change these perceptions. And if I start explaining, you will reason with me, and we can be on the same page and you will get better. So you have to share the decision. Then when you come to make the education, explain sensory nerve function, because messages are taken from the periphery to the central nervous system to the brain. So from the neck, if we are using the neck, so anything around the neck at the initial stage and up to now, messages are taken to the brain, and it is the brain that always interprets that there should be pain around the neck region. And these nerves, they are the ones that carry the functions. That is why there can be a tissue, intact tissue, but if the nerves are not functioning there, then messages cannot be taken to the brain and there can be injury without pain. You can give example, for example, with the case of individuals with diabetes, like diabetic foot. The structure, the anatomy of the foot is intact, but they may get an injury without knowing, because those sensory nerves are not functioning and they are not conveying the message to the brain. So the brain, even if there is injury, will not pass in message because no message was taken to it for danger. So there will be no message sent down to that segment that there should be pain, you should withdraw, you should go and seek medical attention. So explain the sensory nerve. Then explain the descending modulation, which is the messages now the brain is now sending down, and how it modulates that if there is no danger, then there shouldn't be pain. And if there are some activities and some educations, now you are happy, then it will send some descending messages to suppress those sensory input, and then there won't be pain. Explain brain processing of the sensory input. How do they process the message? Okay, they now classify this message as dangerous, as a threat. There should be pain. They classify this message as not a danger, no threat, no pain. Then homework. There should be something that you will give them after educating them that they should go and study at home. The materials I developed, they are in open access, so you can access them from online. So instead of leaflets, because from the title you can see I developed culture-sensitive materials to educate patients on pain. So leaflet, I also consider it not so compatible with our population because a lot of our patients cannot read. Videos, also a lot of our patients, they need a very smartphone, and they need internet, all those things to download the videos, to watch the videos, they need smartphones. So I have to develop an audio, like an interview between the healthcare practitioner and a journalist. So questions regarding pain, the journalist is asking, okay, doctor, you said you are going to explain something about pain. I think pain is not important in our life. How do you see, doctor? And then the doctor will be responding. So all the questions that they need to also know more related to the pain, the journalist is asking while the doctor is responding. So that's the audio I developed, and it is available. So in memory cards, in small phones that can have radio stations, they can put the memory card, then they can just listen to that. Then there should be questions and answers where they want to ask questions, where they want to play a role, and application of that in daily life, how exercises can make them to have happy hormones released in their body, and then they will start forgetting about pain, they will feel happy. All those things need to be integrated. Then for the exercise therapy graded activity and exposure, there should be goal setting, then identification of body functions, activity limitations, participation restrictions. All from the assessment you had, you will know where they are able to do, where they are unable to do, and the contextual factors you get. Then you have to share the decision. How do we achieve it? It is possible. Then tackle maladaptive pain or exercise beliefs, where they think exercise, movement can make their pain worse. You have to tackle it together. What are the potential barriers for them to exercise? Maybe they think there must be a space. You can now adjust and give them exercise that do not require space. All this need to be targeted. Then improve relevant lifestyle factors that can optimize exercise conditions, sleep hygiene, stress management, healthy diet, all these ones. Then identify activities that are avoided versus the ones that persist. So you have to check what are the exercises that these patients are avoiding and what they are still persisting. So this is similar study published by also my colleagues in Belgium. So maladaptive beliefs from what you have all assessed? If yes, then you have to add pain neuroscience education as part of the treatment. During your assessment, is the patient having sleep disorders? If yes, you have to add sleep management. Is the patient having stress intolerance? If yes, you have to add stress management. Is the patient having poor diet? If yes, you have to add nutritional care, healthy dieting. Are there activity limitations? If yes, you have to include physical activity program. So when should you give manipulation and manual therapy? in some of the guidelines, these are indicated. So can I have some comments from colleagues? Colleagues, are we tired? Colleagues, are we sleeping?
No, sir, we're not sleeping. No. But it's been a long day, though.
So as I have explained before, if there are biological attributes to the pain, then you can administer manipulation and manual therapy. For example, neck pain with movement restriction. Instead of you to now tell your patient that there is something serious in the spine, there are these degenerative changes, there is this instability, there is this. Now, since there is restriction, so if we move a joint, we improve its mobility. So the reason why you are now giving the patient manipulation, manual therapy, is to improve those range of motion. And when he sees those range of motion improving, he has no more questions and no more worries. But if you attribute your manipulation to a spinal diagnosis, that there is this herniation, there is this, that is why I am given this, then you have more to do. After giving the manipulation, smart patient will now ask, okay, that displacement is no more there. Those degenerative changes, are they no more there? You have now removed them. Then you have to give genuine answers. And if your answers are not genuine, when he go and do another X-ray and they still tell the patient that there are still degenerative changes, there's still a prolapse, then he will go back to his fear and then the pain will continue to be there. So you have to know which explanation you give as the basis for giving your manipulation or manual therapy. This is what I want to add. Omar Ahmad, you want to talk?
Yes, sir.
Yeah, you are unmuted. You want to talk?
Yes, sir. I think you have said it already, sir.
Okay. So when you give intervention, there should be follow-up ideally, even if it is not a research. When the patient is better, okay, can I get a feedback from you after 2 weeks, after 4 weeks, after 6 weeks? So that you will also have confidence that the management you have given, the result is not just for a short term. Okay, I think now your condition has improved. So no need for you to be consistently coming here. So you can continue with what I told you. Be careful with your thoughts. Don't be so negative. Don't do this. Don't do this. Continue with the exercises. Continue doing this. Run your normal life. But get back to me maybe after 4 weeks. Let me just hear from you. After 4 weeks, maybe the patient will pass coming back from his work or from his business. Doctor, how are you? Yes, you said I should pass through. Are there new complaints? No, no complaint. I've been normal. So that will tell you how long-term the result can be for the interventions you have given.
Sir, good afternoon once again. Yes, please, the standard you are giving us now, possibly is this normal standard in developed worlds. Like in our own setting, I'm talking, yes, in our own Nigerian setting, let's take, for instance, these are realities that happen. Let's take, for instance, I bill the patient, I assess the patient for a cervical condition, and I billed him for about 8 or 10 treatment sessions. And possibly after the 3rd session, this patient is possibly through my manual therapy and manipulation with some educational exercises. this patient is okay after the third or fourth session.
Yes.
Will I now tell the patient that he should stop coming because I still owe him about 3 or 4 more sessions or even 6, 7 sessions? So will I tell this patient to stop coming that he's okay? So these are realities in our own climate. So I wanted to talk more on this.
Okay. Some things we have to talk about evidence-based practice, while some things we have to talk about ethics. If I have billed a patient for some number of sessions and the patient got better before those number of sessions, what are those things I have planned?
Yes, sir. The things I have planned already are working for the patient. That's why he came back, and from the other assessment, the patient tell me he's getting better with the treatment he's getting. So now, will I still tell the patient to come so that he can complete his sessions, or I should follow the normal ethics or professional guide, or tell the patient you are okay, you have been discharged?
So this is what I am saying. I said if your initial plan is only about pain and there is no pain now, ethically, you have achieved what you want to. But if in your plan, you have planned to educate the patient, you have planned to also remove some maladaptive beliefs, you have planned also to improve his fear, you have planned to improve many things, muscle strength, the muscles in the neck are already weak. So it is good now to say out of 3 things we have planned, we have already achieved 1. That is the issue of the pain. So in that case, you can work towards achieving the remaining things. But if you have completely achieved the whole aims of managing your patient, so usually we have some follow-up interventions that are given, even if you have achieved your aims, which are few sessions on top of the ideal sessions to get the results. If you do that, and ethically, you want to do the best for your patients. Okay, at the 7th session out of 10, we have achieved all what we want to achieve. Should I make a refund for the remaining 3 sessions? Where ideal interventions are given.
Now, this patient has paid to the hospital. Will I now tell the hospital to refund this patient?
Yes, because let me give you an example. In orthopedic hospital, National Orthopedic Hospital, Delaware, I practice. For example, a patient may be billed that we are going to admit you, this your condition with the surgery, with everything, we expect that you should be in the hospital for 3 weeks. And after 2 weeks, the patient is better, he has been operated, is ambulant, can be discharged. So the patient is due for refund. So the remaining extra week that the patient has paid for, including the feeding, the bedding, the other interventions, and even in pharmaceuticals, if there are medications received that the patient has not yet utilized, they take them back to the pharmacy and then they get refund from it. So why not physio? We should also work for betterment of our patients. We shouldn't just be for ourselves, not for the patients as well.
Sorry, sir, can I speak to this matter?
Yes.
Okay, so I believe that Dr. Enaoro is working in University of Medical Sciences. I don't think that, yeah, you spoke about the, it's not every hospital that can actually refund the patient. And then if I'm talking about this matter, I would like to say that we don't discharge patients abruptly.
Dr. Titi, I cannot hear you.
Can you hear me, sir?
Yes, now I can hear you.
Okay, I said we don't discharge patients abruptly in physiotherapy. We start by spacing out their treatment. So I don't believe that this case scenario can happen very often. Yes, a few can happen because some patients get better, irrespective of the normal prognosis of their condition. But it's not a very, very common thing. So you would not probably, of course, we've been working, we have a lot of experience. So we would not bill, for example, maybe a condition that you know that, oh, if after like 5 treatment sessions, the patient is going to get better, you wouldn't bill the patient for 10 sessions. You won't do that. It would have been better if you said, okay, let's just give it, okay, one extra session, so that you build the patient for like 6 sessions. And then if you feel that the patient needs more than that 6 sessions, then you ask them to pay for more. So I don't expect that this scenario will happen very often. But if it happens,
I also believe that this shouldn't be a common practice. But I am also of the opinion that if surgeons, pharmacists, medical laboratory scientists, if their services that they are given to the patients have ended because the patient is going to be discharged and the patient is due for a refund, we should as well have this in physiotherapy. We have billed the patient. Let's imagine. There was a time I was handling a patient, and unfortunately, due to some other reason, the patient died. We made a refund to the family. They informed us that unfortunately our patient has died due to something. Is it accident or something else? We made a calculation and there was a refund for the patient. So we shouldn't think it is only in the developed world that some, flexibilities can be applied. So we should also try to see how these kind of things, we can also as well happen to be patient somewhere. And if these kind of things will happen, if we haven't received the service, we should have the refund.
Well, sir, I'm not arguing about the refund, and the point of getting the refund is not because the patient will not get the refund, or we are not trying to protest it. But
Dr. Nauro, let's have finished, then you can respond.
But it's because the patient is going to be the one to go through, at least most hospitals, to go through the whole rigors of trying to process the refund. It won't be you. And then it will be as, it will look like a misjudgment on the part of the physiotherapist, because why shouldn't you know that your patient will get better after 3 treatment sessions? Why build the patient 10 treatment sessions? I don't know if you get, but as physiotherapists, there's always something. Physiotherapy, I usually say, is not just for the ill, it's also for the healthy. There will always be something to do for your patient, even if their pain has gotten better. I had the patient that used to come in, okay, though I didn't bill him, but after seeing him for a while, it was cervical issue too. After coming in for a while, he was fine. He's a prof, and I told him to check back. Sometimes I ask my patients to come in. When I see that they don't really have symptoms like that, I actually ask them to show me their own programs, because patients shouldn't stop on programs because their symptoms have been abated. Yes. Because now it becomes prophylaxis, not treatment curative anymore. So there's always something to do. For example, your patient came in with knee pain due to knee osteoarthritis. The patient's knee pain has subsided. There's always some muscle conditioning to do. There's always something to do for your patient. It can be once in a month. It can be once in 2 months. But not abruptly discharging the patient.
Okay, let's hear what Dr. Enauro want to talk about.
Yes, thank you very much. Just like I emphasized earlier, do you know there is this management meeting they do often, and they try to look at what the hospital, like our own kind of system we practice here. Like our NHIS is not as developed as in the NHS world in the UK or the European world, where they get money directly from the patient's health insurance scheme. So to them, the moment you come for treatment, they are being billed for that. This also happens in the NHIS setting in Nigeria, but it's not that frequent you see patients come with NHIS sum. Like in my setting, for instance, when patients come with NHIS sum, they tell you the number of sessions the physiotherapy can treat. So whenever I treat, I make a documentation on it so we can get a refund from the government. But in a case where the patient has to pay through their own purse, there's already a standard by the hospital, which I believe also exists in most other hospitals. There's a standard for the hospital. So if I treat a patient and maybe about 5-6 patients at the end of every month, they have to go and ask for refund. The management is going to definitely come back and ask me, what is wrong with me that I always send patients to get refund, because they will not be happy with me. So these are issues I think we really, really need to be very optimal about, because in the case of medication, like in the pharmacy, they can always return the drugs and the drugs will be bought by somebody else.
Okay.
But not in our case in physiotherapy, where I have to be, because that is the standard the hospital has set.
If I may come in now, in this case, we are dealing with chronic neck pain here. In chronic neck pain, you hardly see magic in the treatment of the pain. That 1 session, 2 sessions, completely all the maladaptive beliefs, the education, the pain intensity, the disability, everything will disappear in few sessions, 1 to 3 sessions. So I don't think we will have this challenge with chronic neck pain. But with acute is expected to subside within a short period of time. Only few of the acute will now advance to chronic stage. I believe after the assessment of what the patient is presenting with, we should be able to adjust clinically to know on average, this patient will require so number of sessions. And only on few occasions, the patient may not need up to the number of sessions you have planned for. And I said, unless if in your plan, you have only planned to achieve only one thing, for example, only pain. If there is no pain, your patient has to go. But if there has been weakness, there has been limitation in range of motion, there has been some fear, there has been lack of adequate education on pain physiology, there has been, so you can work towards other things as you have eliminated one of the aims. So I think we have come to the end of this workshop, but in chronic pain management, usually it's not something hands-on. Only if there is need for biological issue that require manipulation, maybe some hands-on things may come in, but there are things to be explained and then they have to be applied in the real world. But are there questions that I need to entertain to?
Yes, sir.
Yes.
So thank you for this wonderful presentation. So I have like 1 or 2 questions.
Okay.
So I have an experience. There is one patient came to me with chronic neck pain.
Okay.
In that situation, the neck was rigid. We cannot even assess the neck in terms of range of motion and
Okay.
other things, because the neck it was rigid actually.
Okay.
And according to this presentation, it happens that I learned the patient was having kinesophobia, like that. Even he wasn't even allowed to assess the neck in terms of range of motion and other things. So in that situation, even when I saw through his X-ray, there are a lot of degenerative changes and other things. In fact, the neck was so rigid. So he wasn't even allowing me to do some exercises, or let me say other treatment apart from massage.
Okay.
So in this situation, and when I asked the patient to come back, he don't come back. So sir, in this situation, how can we treat such kind of patient? Then question number 2.
Okay. I'm listening.
Question number 2. Okay. So another patient also come to our department. From the doctor's diagnosis, it was a chronic lumbar spondylosis, which it happens that even through the X-ray you can see it. But during the assessment, all back assessment, especially DCT, because I was expecting to get a positive result using when I administer DCT, but but it was negative. There's no pain at the back. But he is having pain at the lower limbs, and his lower limbs are very weak. So my question is that is this possible for a patient having a chronic low back pain, especially at the lumbar region? The patient doesn't have pain at his lower back. This is my questions.
Okay, thank you very much.
For the first question, a patient that is coming with pain, tenderness, and limited range of motion in the neck region, I think it is another red flag that that patient has to be screened for ankylosing spondylitis. So probably the patient is having ankylosing spondylitis, has to go for investigations in the radiology, the imaging, and also in the laboratory, the blood tests, to confirm if the patient is having ankylosing spondylitis. So probably you started managing thinking it is maybe an acute neck pain, while the patient is having a systemic disorder. So that should have been screened for, and if he's having ankylosing spondylitis and the patient has to receive adequate medical care, then continues also physiotherapy for ankylosing spondylitis, not for neck pain. Then the second question, for someone to have chronic lumbar spondylosis, no pain, and to have weakness, chronic lumbar spondylosis in physiotherapy and even in orthopedic practice may not be the ideal diagnosis. If there are degenerative changes, yes, it's lumbar spondylosis. But is it symptomatic or non-symptomatic? And if their investigation stopped at only X-ray, it may not reveal other deeper affectations. There could be weakness of the lower limbs, loss of some functions. It probably maybe the patient is having presentations of stenosis. So if there is lumbar stenosis, then the patient may be having weaknesses without pain in the lower lumbar region. So I think the investigations and the examinations have not been adequately carried out.
Okay, sir. Sir, another question is asked.
From the same you?
Yes, sir.
You start paying
sir,
me.
I am sorry, sir. Sir, actually,
yes.
Most of the patients that came with complaint of the back pain as a result of lumbar spondylosis, because it happens that 90% of the diagnosis from the doctors, lumbar spondylosis. But when I go further, I find out that most of the patients I have been treating, because I don't normally depend on what the doctor said. So when I did my other test, it happens that most of my patients I have been seeing, they presented with hamstring tightness and also sacroiliac joint dysfunction. And most of the time, when I treated them, sometimes I just stretch the hamstrings and do some kind of exercise, and it find out that the patient is doing well. So, sir, I don't know if my findings is right, because most of the patients I check for the SIJ and hamstrings, I find it positive. So I don't know if it is regular that way.
So I have already mentioned, I said first, is the patient presenting with something acute or chronic based on the definition? In acute, you can easily relate it with biology. But in chronic one, I have already explained that radiological investigations may not always be in agreement with your investigations. And in that case, you have to work with your investigations. Healthy individual that has no symptoms can have signs of degeneration. And if the X-ray alone is taken to a radiologist, okay, based on this radiological finding, what is the diagnosis of the patient? He will still say lumbar spondylosis, while there are no symptoms. So we should not always rely on radiological diagnosis on patients with chronic neck pain, unless if by our examination there is correlation. So we have to be mindful of this. And while explaining to the patient, we should not also emphasize on that spondylosis. We should emphasize on telling them how these changes can be available even in healthy individual without any symptoms. These are part of life. It's part of the wear and tear that can happen in life, and there may not be symptoms. Someone may have them for the whole of his life without symptoms. So we need to emphasize this so that those fear and other associated psychological things that can happen because of thinking that the spine has serious pathology will disappear in the patients.
Thank you so much, sir.
Yeah. Are there more questions? So if there are no more questions, I think we have to call it a day.
Good evening,
nice.
sir.
Yes.
Yes, sir. Thank you for this wonderful presentation, sir. We have learned a lot. And my question is, so how do we screen for red flags with regards to neck pain?
Okay. I have mentioned in my earlier slides, I said you have to look from the history and the initial observations to see if there are things that are neoplasms, cancer pains, usually they don't get better. So it is a red flag that this patient should go for screening. Probably maybe there is a cancer. Or patients that by some examination of the necks, there are issue of dizziness, blood vision, you'll start suspecting that probably maybe there is insufficiency in the the arteries that are supplying the brain. So it is from the history and the observation and the examination that you will think there is something serious. The patient has had an accident, never had an X-ray, has been having persistent neck pain in the neck region. Only TBS was given for all these months, 3 months, 4 months. You will suspect probably maybe there is a vertebral fracture in the cervical region. So you also send the patient for investigations. So it is from what you observe, what you get from the history, that you will suspect that there may be some red flags that you shouldn't address the patient first. There is need for referral or further investigations.
All right, thank you, sir.
Yeah, well. So thank you very much, participants. It was a great pleasure interacting with you, and it is indeed a good one because we were very interactive. So many contributions from colleagues. I appreciate your audience. Till we see again.
Yes, sir.
Thank you very much, sir. Thank you very much. It was a wonderful.
Thank you very much, sir.
You're welcome.
Okay. Thank you.
Thank you, sir.
Okay, thank you. I hope there are no questions in the comments.
Thank you, sir.
Okay.
Thank you, sir.
Okay, thank you very much. Nice meeting you.
Thank you, sir.
Okay.